So all of us know medical science is a rapidly advancing field where yesterday's fact may become matter for the archives to store, and today's fact may not find agreement with experts of tomorrow. So continuing medical education is an integral part of medical profession, and this webinar will cover diverse aspects of cardiodiabetology, and I'm sure it will immensely contribute towards better patient care. The first session is on lipid profile. I'll hand over the session to Dr. Sangram Brother to initiate the session. Dr. Sangram Brother. Dr. Piyush Jain is the head preventive cardiology at the prestigious Fortis Escorts Hospital, Delhi. Dr. Sangram.
Yeah, good morning, sir. Good morning to everybody. I welcome one and all. I now request Dr. Piyush Jain to speak on deep dive in lipid profile, which is a very important topic. Over to you, Dr. Piyush Jain, sir.
Really thank Dr. Manoria and Dr. Sangram for inviting me today. And without wasting any more time, let me just say what I want to say about the lipid profile, which seems to be very simple and something that is practiced by every clinician in day-to-day practice. But let me just say that a routine lipid profile, what do we actually measure directly? We measure total cholesterol, triglycerides, HDL cholesterol, and LDL cholesterol. And then there are certain derived values like non-HDL cholesterol, total cholesterol to HDL-C ratios. But then there are other parameters like ApoB, Apo, A1, their ratio, LDL particle size, LDL particle number, certain other assays like enzymatic assays, ApoE levels, ApoC2, C3, and then genetic testing. So I want to put everything in perspective in next 18 minutes or so, because there may be a lot of confusion in our mind as to what to use and what not to use in our day-to-day clinical practice. The first thing that I would like to say about the lipid profile is the recommended methodology. So there is a difference between what is the gold standard methodology and what is approved in this country by NABL. And this may be different. And why it may be different? Because these gold standard technologies, about which I'm not going to talk about much, things like gravimetry, ultracentrifugation, NMR, and immunonephrolometry, etc. These are used for reference and calibration, and routine measurements often employ automated assays calibrated against these reference methods. So the whole purpose of knowing about these gold standards is that we should know that a lab where we are sending our patients, they are calibrating their automated assays against these gold standards from time to time. That is number one. The second point I would like to say here is that certain parameters like VLDL are never measured directly unless we are doing ultracentrifugation. So in a routine enzymatic assay, automated assay, VLDL is calculated as triglyceride divided by 5 when the triglycerides are less than 400, and triglyceride divided by 6 if the triglycerides are more than 400 but less than 1000. But when the triglycerides are more than 1000, this calculation also goes wrong. The other thing is we have patients coming from other countries like UK, Bangladesh, where the units of measurement are different. That is 1 millimole. So 1 millimole of cholesterol, whether it is LDL, HDL, VLDL, whatever it is equivalent to 38.5 milligram per deciliter, the unit which is used in our country. And 1 millimole of triglycerides are equivalent to 88.5 milligram per deciliter. So the issue which has been discussed in the past few years over and above these routine measurements and the methodologies, whether we should do fasting or non-fasting lipid profile. So routine lipid profile is actually has been, and it's still being done in a fasting state with instructions to the patient that you have to take a usual diet for 1 week, no alcohol for past 24 hours, and an overnight fast for at least 8 hours, if not 12 hours. But the recent guidelines have indicated that we could accept the non-fasting lipid profile because the differences in the values between fasting and non-fasting levels are actually nominal, particularly in case of HDL and LDL. So non-fasting levels are actually convenient. What do we do when we do a non-fasting lipid profile? So that is good enough to make clinical assessment and decisions. But however, it is said that if the triglyceride levels in non-fasting states are more than 400, then it should be repeated in a fasting state also. Okay, let's now straight away go on to other parameters, and let's see whether there is an incremental value of other parameters like ApoB, etc., and start with ApoB. So we know that the risk of the cardiovascular events are better correlated to the number of atherogenic particles than the LDL-C levels. LDL-C reflects basically, it's a reflection of the ApoB, and it's a surrogate marker, but that is not the whole story. So each atherogenic particle contains one molecule of ApoB, and therefore ApoB is a direct measure of the number of circulating atherogenic particles. So you may ask me, what are the lipid particles which contain ApoB? So these are not only LDL-C, but also LPA, VLDL, the remnant particles, and then of course intermediate density lipoprotein. So it is possible that LDL-C is normal or low, but the triglyceride-rich lipoproteins like VLDL, VLDL remnant, and IDL, they are high, and high ApoB may be raised despite a normal or low LDL-C, and that reflects high risk in the absence of high LDL cholesterol. And this is often seen in patients who have got insulin resistance, which is very common in our country, along with small dense LDL-C preponderance. So it was thought that ApoB may be superior to other cholesterol indices like LDL-C to assess the risk of vascular disease. But let's just see what is the evidence for that. So, intra-heart study, where ApoB to ApoA1 ratio was found to be strongest risk factor. Without going into the details of intra-heart study, I must say that it was a case control study, not a conclusive design. And then there were methodological issues also, like underestimation of the impact of diabetes mellitus and hypertension, which was self-reported, and other things. So intra-heart study was actually not really something on the basis of which we can start using ApoB as a risk marker. So what about other studies? Another large study from Sweden, it was called Amore study, where patients had a high apolipoprotein B and low apolipoprotein A1 in the general population, and what it found was that it does lead to an improvement in the prediction of fatal myocardial infarction. And the study was very large, actually, around 1.75 lakh patients with a median follow-up of 66. So what this study was found was that ApoB is a stronger predictor of risk than total cholesterol to LDL-C ratio or HDL-C per se. Another study, the Northwick Park Heart Study 2, also found the same thing, that the ApoB to ApoA1 ratio had the strongest effect on the relative risk of CHD events. But having said that, a very large study, ERIC study, which you may be aware, it was one of the largest epidemiological studies conducted in United States in different, races. LDL-C was found to be the best predictor still, and the risk of ApoB was eliminated in multivariate analysis. So it is not 100% certain that ApoB is certainly superior to LDL-C in risk prediction as far as the risk prediction is concerned. So the question may be asked here is whether we can use some simpler parameters like non-HDL-C cholesterol. Non-HDL-C is basically total cholesterol minus HDL-C, or you could also calculate it by measuring LDL-C plus VLDL-C, which comes to the same. There's a difference between the two. ApoB levels, they tell you about the concentration of pro-atherogenic lipoproteins, whereas non-HDL-C levels, they tell you the concentration of cholesterol transported by these pro-atherogenic lipoproteins which contain ApoB. So here, let's talk about the health professional follow-up study of 18,000 patients, males initially free of coronary heart disease, and 6 years of follow-up. And during this prospective trial, what was found was ApoB was still the strongest, predictor of future myocardial infarction. But look at the figure of 3.1 versus 2.76. Non-HDLC was not far behind, and both were superior to LDL-C as far as the risk prediction was concerned. So from this study, one could say that ApoB and non-HDLC, they perform more or less the same as far as the risk of prediction of myocardial infarction during next 6 weeks in males is concerned. Then non-HDLC in another study, which was a smaller study in young people, showed that a non-HDLC was the strongest discriminator for myocardial infarction among all studied lipid parameters, including ApoB. Also in type 2 diabetes mellitus, subgroup analysis of health professional follow-up study, once again, the performance of ApoB and non-HDLC was similar. So here we have another study in women. Once again, if you see the figures, the adjusted hazard ratio for CV events, ApoB and non-HDLC both performed equally well. Framingham heart study, that also showed that a simple parameter like total cholesterol to HDLC ratio performs same as ApoB to ApoA1. So what does that all mean? To my mind, it seems that adding on and measuring ApoB and ApoA1 in all patients to assess the risk of future events is actually not justifiable in the light of all these investigations, where simple things which can be derived from routine lipid profile like non-HDLC and total cholesterol to HDLC ratio at no additional cost is something we really should not be using ApoB, ApoA1 in routine clinical practice. That is my view. However, and also the clinical guidelines also base their decisions still on the LDL-C as the primary target and non-HDL-C as the secondary target. So the use of ApoB in routine clinical practice is not justifiable at the moment. It is a good research tool for risk assessment in populations where resources are unlimited or resources are not wanting. But for a patient, we have to offer a cost-effective treatment, and cost-effective treatment means cost-effective diagnostic workup also. So we go further and talk about another aspect, that we have, LDL-C, we have HDL-C, we have, other lipid particles, and they could be subgrouped into things like small dense LDL or number of LDL particles, or most atherogenic lipoprotein particle like HDL-2B subclass. So is there any justification for measuring small dense LDL? Let us see first. So case control studies, as one can see in this slide, there have been 6 prospective case control study, 1 negative study, 5 studies were positive, but no independent association with between small dense LDL and coronary heart disease in 4. So this independent association between small dense LDL and coronary heart disease, even though it was found in 1 study, but not after correction for total cholesterol to HDL-C ratio. What about prospective studies? Similar thing, which means that independent risk prediction by small dense LDL measurement, which can be possible by ultracentrifugation, is actually not really going to add to our knowledge, and it's routine determination, or we also don't know whether therapeutic manipulation of this small dense LDL is going to be beneficial or not, and it is not recommended. It is not recommended at the moment in any of the guidelines. So we also know that small dense LDL, we can actually guess very accurately, rather accurately, by just looking at the clinical profile of the patient. If a patient has got diabetes mellitus, patient has got metabolic syndrome, or the patient has history of smoking, they already have a preponderance of small dense LDL, and this is further supported by increasing triglyceride levels. The small dense LDL preponderance actually starts happening with a triglyceride level more than 150 or even more than 100, and therefore actually there is no need for measuring the small dense LDL in routine clinical practice. Now, there's another thing, right? If you do a triglyceride to HDL-C ratio, and if it is more than 3.8 in Asian subjects, it tells you that the patient is likely to have LDL-C. So no need for doing, further extended lipid profile and ultracentrifugation for all patients to measure what is the small dense LDL level as compared to the larger. What about LDL particle number? Well, there are once again case control studies and prospective studies, and overall no independent association with number of LDL particles and coronary heart disease in most of the, at least half of the studies. And then of course the number of LDL particles can be measured only by NMR, which is actually a research tool and not something which should be done in clinical practice. So the other, the studies like, EPIC Norfolk prospective population study, they have shown that the non-HDLC actually performs very well. It performs very well as compared to LDL-C, as compared to LDL-C size, as compared to LDL particle number. And therefore, once again, my submission is that if we do a routine lipid profile and also closely look at non-HDL-C and total cholesterol to HDL ratio, it will give a very fair idea about the future risk. And we really don't need to do either, ApoB, ApoA1, or LDL particle size or LDL particle number. I'm just about to finish, because here I'm going to say just a few words about LPA. LPA is something, the recommendations now across the board advise and recommend that it should be done at least once in the lifetime of a person. I agree with that. But for a country like India, where even a lipid profile is not done for each and everybody, even at the age of 18 years, not to talk about 8 to 10 years, which is the right time to do it for everybody, because of the economic considerations, we have to select the patients. Now, who are the patients where LPA should be estimated for risk assessment, future risk assessment? So one is a person who has got a premature atherosclerotic cardiovascular disease. Then those who are first degree relatives of these patients with premature atherosclerotic cardiovascular disease, or anybody who is found to have elevated LPA, his parents or siblings should have an LPA. Then severe hypercholesterolemia, LPA should be measured. Why? Because there is a double jeopardy, and we need to actually treat these patients more and more aggressively. And then, of course, when LDL-C response to statins is less than anticipated, or when we want to fine-tune the risk, this is controversial. But another thing there where LPA should be measured in all patients is when young patients get ischemic stroke. But the problem with LPA measurement is there because there are obstacles, the kind of processing, fresh versus frozen samples, milligram per deciliter versus nanomole concentration. It is in nanomole per liter, which is actually recommended to know the actual LPA particle number. And that is what matters, not the LPA measurement by milligram per deciliter, because there may be a similar concentration but a different number of particles. So the recommended measurement technique for LPA should be used, which is recommended by the WHO, and standardization of assay is very important. Unfortunately, in our country, LPA is measured by milligram per deciliter, not nanomole per liter, and that should be changed. Okay, so I conclude here because I'm getting short of time. So my conclusions are: routine lipid profile provides enough information for clinical management in day-to-day practice. From simple parameters like total cholesterol, LDL, HDL, triglycerides, you can actually derive non-HDL-C as well as the total cholesterol to HDL-C ratio, and they are very good markers of the future risk. Clinical decisions may be taken on the basis of these fasting or non-fasting estimations, but of course, important thing is that the correct methodology should be used. Non-HDLC and total cholesterol to HDLC ratios provide as much information as ApoB or ApoB to ApoA1 ratio. LDL-C subclass or LDL particle size or particle numbers, they do not add to the risk prediction over routine lipid indices for clinical information, and we should just proceed with routine clinical profile, lipid profile using the correct methodology. LPA measurement may be reasonable in specific situations, but at the moment, I must say, it is only for risk assessment, not for management in significant way, because we don't have outcome studies which are undergoing at the moment, and we will know about the benefits of lowering of LPA by the agents that are available like pilocarsen and related compounds very soon, and then maybe this will become a prime time at that time. Thank you very much. I will stop here.
Thank you, sir, for your wonderful comprehensive discussion. So what is the importance of regularly doing LPA? We have to do regularly LPA, or?
Actually, LPA is something which is genetically determined, and LPA should be measured only once in the lifetime. Sometimes it may be changed because of intercurrent infections or other things, but that is temporary. So when a patient is clinically stable and asymptomatic, LPA should be measured at that time, and that should be the benchmark. It should not be repeated. And that may change actually with the availability of drugs which are effective in reducing the CV events. Then maybe we have to do it periodically, but not at the moment.
Routine, yeah. Yes, sir,
Okay.
please.
Yeah. You have beautifully identified, in fact, the history of lipid profile. But one thing it is important for me. I see in our clinical practice, more than 50% of patients are diabetics. And therefore, I still believe that whatever you pointed out, triglyceride to HDL ratio offers great help over and above the total profile. And the second aspect I just wanted to comment upon, our LDL-C targets are becoming less and less. We started from 100, then it became 70, then it became 55, and I suppose right now it is 40. So in that context, what have you to say?
So I showed a slide where triglyceride to HDL-C ratio more than 3.8 correctly predicted the presence of LDL pattern V, which is atherogenic. And therefore, it is very simple to measure, and it should be done in clinical practice. And this is particularly so when we find that the triglyceride levels are high and HDL-C levels are low. That is one, and we do it on a regular basis in addition to total cholesterol to HDL-C ratio. And second, of course, the non-HDL cholesterol. The second point is regarding the lowering of the LDL-C targets. My personal view is that it is safe to reduce LDL-C below even 30, but as you reduce the LDL-C below maybe 55, going to 40 and then to 30, safety is demonstrated, but efficacy points are actually decremental. And nobody has actually found that there is a decrease in the mortality as a result of marked decrease in LDL-C cholesterol as because of as a result of aggressive therapy. So that should be kept in mind, that you have to do cost-effective treatments also, and in the interest of cost effectiveness and also not overloading the patient with multiple medications for lipids, because patients have other priorities also. Doctors also have other priorities: hypertension, diabetes, and CHD per se. And then, of course, they may be having other comorbidities. The number of medications that is now being propagated is tremendous, and this is not good. So if we are able to reduce the LDL-C to something like between 40 and 55, that is good enough, and we should start looking at non-lipid risk factors like smoking, about which nobody is very serious. So this is my view about it.
Carry on, Dr. Sangram. Yeah.
One of the issue is that when LDL level is above 100, usually there's decrease in the mortality. Once the baseline LDL is less than 100, usually there's decrease in the events, and mortality, as you said, may not be affected. But the
Yes.
most important issue is we have different cutoff points for primary prevention, then for high risk, very high risk. But none of the lipid profile across the country have seen that the normal value continues to remain same as for a normal individual. The pathology report does not write the cutoff point for primary prevention is this, cutoff point for secondary prevention, high risk, very high risk. So I think that is the most important issue that should somehow be corrected, because when the patient sees the report less than 100 or 100, he thinks everything is okay, although he may be suffering from myocardial infarction or recurrent coronary events or even a stroke, where certainly this is not the correct value. And second thing is, if the triglycerides are high, you will straight off opt for ApoB, or you will still continue to rely on LDL.
No, when triglyceride are high, we should actually calculate non-HDLC and triglyceride to HDLC ratio for risk assessment, and we have to treat these patients according to the either CSI guidelines or the American guidelines, or European guidelines also are good in this respect. So non-HDLC should be calculated. ApoB, I'm not very enthusiastic about it, because in the interest of cost effectiveness, it is not nice to subject a patient to routine lipid profile and then ApoB, ApoA1. These are costly things. These are not for our country. This is my view.
The context is very important as far as the clinician is concerned. So regardless of the levels, it is our job to explain to the patient if he has any anxieties and what exactly is the status in relation to reports.
Yes.
Dr. Piyush, I want to come in. Thank you very much for making us several points very clear. I want to understand from you, you did not take into account the LDL particle numbers, but you were categorical on LPA particle numbers, if I heard you correctly.
Yes, LPA particle number. See, the measurement of LPA particle number is important, because the LPA concentration measured as milligram per deciliter does not really reflect the heterogeneity of LPA. The LPA particles which are smaller in size but larger in number, they may have a better correlation with the risk as compared to the concentration in terms of milligram per deciliter. So we have to actually calculate the number of particles that is reflected better with nanomole per liter. And there is no actually specific correlation between the milligram per deciliter versus nanomole with LPA as compared to LDL-C and other particles, because there is a lot of heterogeneity in the LPA particle size from person to person, from races to races, and therefore it is always better to use nanomole per liter as the standard measurement, which unfortunately is not done by routine procedures.
The other thing is, when we are measuring LDL, it is a combination of LPA plus LDL. That should also the physician must understand. LDL means LPA plus LDL and not LDL alone.
Yes,
That's right.
That's right.
Any other comments or questions?
Yeah, routinely we should advise direct LDL, or it's sufficient to have lipid profile, sir? Calculation method is sufficient.
Actually, if you look at the recommendations of NABL, both are acceptable. That is number one. But having said that, indirect estimation by Fried-Wald formula is always subject to error, because it's a calculated value, and therefore direct LDL measurement is recommended. But there are different methods for measurement of direct LDL. So the NABL suggests that when you do direct LDL, it should be done by a homogeneous assay. I don't know whether all the labs are doing the same, but the NABL accredited labs should be doing that. Other labs, I really don't know. So if they are not doing it by homogeneous assay, then they should switch over to homogeneous assay, and that is the most reliable method of measuring the LDL. Now, when you do LDL measurement by calculation, you use Fried-Wald formula or something like some other formula which is also there. There are 3-4 formulae. There, the dividing triglyceride by 5 actually gives you a gross underestimation of the LDL levels, and therefore you have to divide this by 6, not by 5, up to 1000, and beyond 1000 indirect LDL should never be measured. It should not be calculated at all. You may find LDL to be 5, 6, or maybe even 0 with that, and that's not good enough.
So with this, we conclude this session.
Yes. Thank you, Dr. Manoria.
Thank you very much, sir.
Again, for a very exciting and a very informative talk on lipid profile. I'll hand over the mic to Dr. Padma Gulati and her to conduct the next session. Dr. Padma, you can initiate.
Good morning, everyone.
Hi, Dr. RK. Yeah.
Yes, sir. Please.
Thank you, sir. Thank you. We now switch over to another drug improving Manoria. Hello. Cardiovascular outcomes by Professor Manoria, who's earlier he was the professor and head Department of Cardiology, Gandhi Medical College, Bhopal, and Dean at Indian College of Physicians and Indian College of Medical Ultrasonography. Over to Professor Manoria, sir. Professor Manoria, sir.
Yes, just a minute. Let me share this over. So for the next 15 to 18 minutes, I'll be talking on this upcoming topic, drug revolution in obesity, improving CV outcomes. Obesity is rocking the entire world, and the statistics are horrifying, as you can see on the slide. Now, for several years, obesity was considered as a risk factor for cardiometabolic diseases, and no lifestyle intervention or conventional pharmacotherapy for overweight or obesity has not shown to reduce the cardiovascular events. We are all aware of the look-ahead trials. You can see both the curves are touching each other. And when we go down the memory lane of the anti-obesity drugs, the fen-pen was withdrawn from the market because of regurgitant lesions, sibutramine because of increased myocardial infarction and stroke, rimonabant because of psychiatric illnesses, and losartan because of increased risk of cancer. But the big change which has occurred during the last couple of years is that obesity is now recognized as a disease. Adiposity refers to a state of excess fat in the body, whereas adipopathy means that the fat has become sick and is contributing to cardiometabolic diseases. And the big message is treatment should be initiated at diagnosis to prevent complications. So adiposity has been renomenclated as ABCD, which means adiposity-based chronic diseases by all professional bodies, because this allows obesity to be treated as a disease along with its complications, and also avoid stigma of overweight obesity, which may have fostered discrimination towards the patient. And look at the number of complications obesity may produce, 229 plus. So obesity is a very important disease at the present state of time. There has been refinements in the criteria for diagnosis of obesity. BMI has been used for several years. It is weight in kg, height in meters square. And for the Indian context, the normal BMI is 23 cutoff. So you can have overweight 23 to 27.5, obese 27.6 to 39.9, and 40 plus is a morbid obesity. But the problem with BMI is that you may have a muscular body and your BMI may be high, and yet you may not have increased amount of fat. Waist circumference is also utilized, more than 90 centimeter for males and more than 80 centimeter in females. Waist hip ratio more than 0.8 in females and more than 1 in males. Waist height ratio is also usually accepted as a good criteria for diagnosing obesity. More than 50% of height, that is 0.5. The best way is to have a DEXA scan, but is usually not available. More than 30% fat in females and more than 25% in males is the criteria for obesity. But the problem with all these definitions is that they do not take into consideration the symptomatic limitation of activities due to obesity. They do not take into consideration the obesity comorbid disease. So in 2025, we have the new definition of obesity, as you can see on the slide. So now we have classify obesity into two categories. Stage 1 obesity, where BMI is more than 23, which is mandatory. The optional criteria are these, which we have discussed, but there is no symptomatic limitation of physical activities. There is no comorbid diseases. But once you have a BMI of more than 23, plus one of the following, that is waist circumference, waist height ratio, or body fat if available, and you have an obesity-associated limitation of the activities or obesity-associated comorbid condition, it becomes a stage 2 obesity. So this is the latest classification of obesity. Now, obesity can be caused by multiple problems. There are multiple pathogenetic pathways. One of the problem is the neurogenic pathway. Now, when you eat healthy food, the nerves in the brain receive hormonal signals from the fat cells, from your stomach, your intestine, and the brain senses how much you have eaten, and then it gives a satiety signal and you stop eating. However, when you repeatedly eat highly processed food, the nerves get damaged and the brain does not receive hormonal signals, and the brain does not sense how much you have eaten, and you may continue to eat. Besides, there's several other factors are involved in the pathogenesis of obesity. There could be socioeconomic factors, environmental factor, behavioral factor, and even genetic factors, and all these lead to chronic inflammation and various diseases. The development of obesity may start in utero and continues throughout life, as you can see on these slides. So you could have genetic causes, or if there's excess gestational weight, there are more chances of the offspring getting obese. Gestational diabetes, inability to breastfeed, increased screen time in children, they continue to sit near TV, unhealthy eating habits, physical inactivity later on, poor nutrition, sedentary lifestyle, economic factors, and so on. So there are multiple factors depending on the age which contribute to obesity. Now, whenever there is excess fat in the belly, it gets deposited at various ectopic sites, and ectopic visceral fat has detrimental effect on various organs. If the fat gets deposited in the liver, it produces muffled, MASH, or even steatotic liver disease, and this predisposes to development of diabetes. Fatty liver is a precursor of diabetes, and many hepatologists believe that diabetes is a disease of the liver for this reason. The insulin resistance also increases once you have a fat in the liver. If you have a fat in the pancreas, it will produce diabetes. A small amount of fat in the pancreas produces diabetes. If fat gets deposited in the perivascular spaces, it produces atherosclerotic cardiovascular disease. It is pro-inflammatory, increases oxidative stress, and so on. And if it gets deposited in the epicardium or in the heart, even the myocardium, it produces HFpEF and atrial fibrillation. And if it gets deposited in the muscles, it decreases insulin sensitivity and increases. So ectopic fat deposition is detrimental and is of serious concern. It produces chronic inflammation, insulin resistance, and several other pathways gets activated. It's also associated with erectile dysfunction. Now, as a consequence of this, during the last couple of years, adipocentric approach has come to the forefront even ahead of the glucocentric or cardiometabolic approach. And here you can see the benefits of reduction in weight. Any reduction of weight is beneficial, as you can see, 0 to 5%, 5 to 10, 10 to 15. But if you reduce your weight more than 15%, there is a chance that your diabetes can undergo remission. You can decrease mortality, cardiovascular, and also benefit HFpEF. So there has been a drug revolution in obesity during the last couple of years, unlike the conventional drugs, which have a lot of side effects, and many of them have been withdrawn after being introduced and approved by various professional bodies. So now we have single agonists like semaglutide, 2.4 milligrams subcutaneously weekly. And the STEP trial shows that you can reduce weight by 15, 16, even 17%. So massive reduction in weight with injectable semaglutide is very popular in the West. Not yet available in India, going to be available perhaps next year or this year late. We have oral semaglutide, 14 milligram, decreases weight by about 5 kg, but trials with 25 and 50 milligram has shown reduction in weight to the tune of 15% or so, although this is still in the process of evolution and not commercial. And the big advance in semaglutide was the SELECT trial, which showed that obese patients who were non-diabetic, already suffering from a cardiovascular disease, you can decrease the primary endpoint of cardiovascular death, non-fatal MI, and non-fatal stroke by 20%. And of course, body weight and waist circumference also reduced. Then we have the dual agonist, TIP, TLP, tirzepatide, which is approved for clinical use by FDA, not available in India at the moment, but available in the Western countries. The dose is gradually increased from 5 to 15 milligram. And you can see it was tested in the SURPASS trial, it was tested in the SURMOUNT trial, and the SURPASS CVOT trial is ongoing. So what this does, when you use this great reduction in weight, 9.5 to 13 kg, and not only this, in diabetic patient, the reduction is to the tune HbA1c 2.07 to 2.59, massive reduction. And the SURMOUNT trial showed that you can decrease weight almost to the tune of 22% or so. And we have cagrilintide, which is again undergoing evaluation. Once weekly combination of cagrilintide in a fixed dose and semaglutide 2.4. And it has shown reduction to the tune of 17%. And we have now triple agonist, retatrutide, which has shown reduction in weight to the tune of 24%. So with the current pharmacotherapy, which is going to be available in times to come, we can have massive reduction in weight with these agents. And several other molecules are in the pipeline. So although initially these molecules may be very costly, but in times to come, because so many molecules are in pipeline because of competition, these drugs will be available at a much lower rate. So what is the end result? When we use the lifestyle modification or the conventional pharmacotherapy, the reduction in weight is to the tune of 5%, a little more, maybe 7, 8, or 10. Endoscopic bariatric procedure is about around 15 to 20, bariatric surgery 25 to 35%. So now we have triple agonist. You can see rate reduction up to 24% or so. They are coming very close to bariatric surgery. In fact, the gap between the pharmacotherapy and bariatric surgery is closing down. So what are the positive trials of GLP-1 receptor in non-diabetics? We have a lot of data of semaglutide in diabetic patients. They have improved CV outcome. The LEADER trial, the SUSTAIN 6, and other trials. Now, this is a SELECT trial which was carried out in 17,000 patients. Semaglutide 2.4 milligram, gradually this concentration was achieved. Mean follow-up 39.8 plus minus 9, 4 months. And you can see patients 45 years or older, pre-existing cardiovascular disease. This is a secondary prevention trial in obese patient, BMI more than 27 and no history of diabetes. You can see a 20% reduction, a statistically significant reduction in the primary endpoint, cardiovascular death, MI, and stroke. Then we have these trials in HFpEF. Now, this is the initial HFpEF trial, which was carried out again with semaglutide 2.4 milligrams. and this was comparatively a smaller trial, 529 patients. The primary endpoint was improvement in KCCQ and body weight. You can see significant reduction, improvement in the quality of life as judged by KCCQ, and significant reduction in weight. The 6-minute walk test also improved. Serious events were less, and the number of cardiovascular events was much less, so nothing much to comment on. Then we have the STEP-HFpEF showed that there is also decrease in the CRP. And then we have the STEP-HFpEF DM trial, again 600 patients or so, again BMI more than 30. And you can see the change from baseline, the primary endpoint KCCQ showed significant improvement. Again, the second primary endpoint, weight reduction was significant. Then there was an improvement in the 6-minute walk test, change in the baseline. So this trial also shows reduction in NT-proBNP, and time to first HF event was also showing improvement. And of course, C-reactive. But both these trials did not consider cardiovascular endpoints. But when the pooled analysis was done of both these trials, the STEP-HFpEF and the STEP-HFpEF DM, you can see time to first HF event or cardiovascular death, there is a significant reduction, p-value is 0.008, and of course, KCCQ and weight change did improve. So the SUMMIT trial was carried out with the objective of primary endpoint as a cardiovascular endpoint, composite of death from cardiovascular causes or worsening heart failure. You can see a statistically significant reduction in the this primary endpoint, and there was also a significant difference in the KCCQ. And the big emerging question, will injective semaglutide and tirzepatide be classified as a heart failure drug for specifically for the obese phenotype of HFpEF in times to come? Maybe. Then we have some data in the obstructive sleep apnea. This is the scale trial with liraglutide, which has shown improvement in the apnea hypopnea score. Surmount trial, whether you were on CPAP or not CPAP, again, it has shown improvement. And the NEFL or MASH and MESLD has also shown trial. This is the lean trial with liraglutide. Semaglutide has also shown improvement, reduction in the fibrosis stage with no worsening of NASH. A cell trial is ongoing. The preliminary results were announced in recent past. And we also have the Synergy NASH trial ongoing with tirzepatide, which has shown benefits. So in summary, when we look at the data of GLP-1 receptor agonist on obesity and its complications, weight loss, we have significant weight loss with semaglutide, 2.4, almost to the tune of 15 to 17%. Oral sema 14, 5 kg. Oral 50, which is in the process evolution, 15 kg. Massive reduction in weight, massive reduction in HbA1c 1.5. Improvement in ASCVD in diabetic patient, leader, sustain, rewind, SOUL, and now non-diabetic. We have the SELECT trial and HFpEF. We have these trials. CKD flow trial was positive in NASH trials. And when we look at the tirzepatide, again, it has several trials. Surmount showed reduction. One trial showed reduction in weight by 22%. We have these trials of SURPASS and Surmount. And for ASCVD, SURPASS CVOT is ongoing. For HFpEF, we have the SUMMIT trial and some trials with NASH. So in summary, obesity is now categorized as a disease and not a risk factor, and aptly nomenclated as ABCD. Drug revolution in obesity is exciting, but stopping drug when the goal is achieved or side effects occur or cost results in regain of weight due to relapsing nature of the disease. Sarcopenia is a problem with all new anti-obesity drugs. An attempt should be made to minimize it by exercise or protein supplementation. Bimagrumab, a human monoclonal antibody, 700 milligram IV every 4 weeks, binds to myostatin and has shown increase in the muscle strength and muscle hypertrophy in a phase 2 trial, and it reduced not only total body fat mass, but increased the lean fat mass by 7% compared to the placebo, which was significant. Thank you very much for your time.
Dr. Manoria, do we have any CVOT outcome trial with tirzepatide in comparison to semaglutide? Because we have data with semaglutide. So is it in cardiac patient wise to start tirzepatide, or we continue with sema?
Surmount CV outcome trial is ongoing. The results are awaited. Surmount CV outcome trial is ongoing.
Yeah. So for us, it is still sema.
Yes.
So what are the limitations of BMI in diagnosing obesity?
Semaglutide.
BMI has been used for several years to diagnose obesity, but the problem is, suppose you have a muscular body, you are an athlete, you are a wrestler, the BMI will be more without any increase in the fat. Opposite to this is, suppose particularly in the South Asian, your BMI may be normal, you may have increased amount of fat and you may be suffering from obesity related complications. So that is the limitation, because BMI does not indicate exactly what is the amount of fat in your body. So that is the limitation. That's why newer and newer definition than current definition I've already outlined. How do we classify 2025?
So does the increase in all-cause mortality in patients of obesity, does it also relate to lower BMI, like if it's less than 18?
Now, in Indians, if you have increased amount of metabolically active fat, you can have obesity induce various complications despite being a normal BMI. Because South Asian, that's why we have a diabetes 1 decade earlier. You may suffer from NASH, what we call lean NASH. You may suffer from other disease without increase in the BMI, or even without increase in even the abdominal guts. That is the peculiar feature of, that's why we call thin fat Indians. They are thin, but they have been labeled as thin fat Indians.
So I would also like to know, like, I mean, keeping in view the latest guidelines on obesity, like it's been classified. Hello.
Not able to hear.
Stage 2, majority of the Indian of stage B, and they are, most of the patients are diabetic or hypertensive. They have some obesity associated comorbid conditions. So are we routinely prescribing these near anti-obesity drugs? I mean, was the scene in Bhopal and cosmopolitan cities like Bombay and Delhi?
See,
Are we using these drugs in such patients?
At the moment, we have only oral semaglutide 14 milligram available in our country, which decreases weight by 5 kg on an average. In some it may be more, some it may be less. Semaglutide injectable is going to be available within a couple of months, 2.4 milligram, which decreases weight by 15 to 17%. Tirzepatide, although approved, is not yet available, which also decreases weight in the surmount to the tune of 22. So these drugs at the moment are not available, only oral sema is available. So
drugs to be recommended time, like keeping in view the coming back of obesity once the drugs are stopped. Do we have to recommend lifetime prescriptions to such patients?
obesity, like other diseases, say suppose you have hypertension, how long you continue treatment, how long you continue treatment for diabetes. So obesity is also a lifelong disease. Although most of these are costly, but now attempts are being made to perform some weaning protocols. Otherwise, moment you stop, they will again gain weight. Although the increase in weight is only to the tune of 80%, so it does not bounce back to the original level. But certainly it has to be taken for a long time, and some weaning protocols are being designed. It's just like other non-communicable disease. You take antihypertensive drugs so long as you take.
Thank you, sir. Thank you so much for your prolific talk on obesity and.
Sir, thank you, sir, for good lecture. Only one question I want: what should be the cause of aspiration pneumonia if the patient is on SEMA or LIRA?
This has been increasingly noticed because semaglutide slows the gastric emptying time. So the food remains in the stomach for a longer time. So suppose you are not aware that a patient is on injectable semaglutide or oral semaglutide, and you directly send it for surgery. The anesthetist during intubation, the food may regurgitate into the trachea and produce aspiration pneumonia. The problem really arises, suppose somebody is on an injectable semaglutide or oral semaglutide, he develops an accident or he develops acute appendicitis, and suddenly you have to operate. Then it becomes a problem. Otherwise, you can stop the drug 7 days prior to elective surgery. But emergency surgery, the anesthetist must always take into point on this. They should aspirate the contents of the stomach, although this is not a guideline.
Dr. Manoria, there is the apprehension that along with the weight loss, more than fat, there is a protein and lean muscle mass loss, which is can be detrimental to many Indian population because they are quite lean. What have you to say?
See, it's true that there will be some increase in the lean body mass, maybe 5%, 10%, or 15%. So you have to take a high protein content in your diet. You have to do resistant exercise and make the individual train to this exercise. And we are having this new monoclonal antibody, which is under evaluation, which has shown not only decrease in weight, but also increase in the muscle mass. So in future, this problem may be addressed.
Thank you.
Sir, what should be the sequence? The number one, the lifestyle modification, then the GLP-1 RA, or the bariatric surgery. What should be the sequence for any patient who is having the
Lifestyle
more than
modification
40? BMI more than 40? What should be the sequence?
Lifestyle modification is for all. BMI 40, bariatric surgery will be the first choice. I think we are already running short of time, so we hand over the mic to Dr. Bhattacharya and Dr. Pandey to conduct the next session.
Thank you, sir.
Sir, good morning. Now the next topic is novel LDL-C therapy with special interest on CETP inhibitor. I invite Dr. Rajiv Agarwal to start his deliberation. Over to you, sir.
Thank you, Chairperson. Thank you, Dr. Manoria, for providing me this opportunity to talk on CETP inhibitors. I think when we talked about atherosclerosis in lecture 1 by Dr. Piyush Jain, there was some controversy regarding the level of LDL-C achieved. And the panel almost stopped at 55 LDL, that this is the best and there is no mortality reduction. To my mind, the aim of lipid-lowering therapy is not reduction of MACE. The aim is regression of atherosclerosis, which is only seen below 55. This is a rabbit hole I keep showing in all the meetings. Atherosclerosis can manifest as ACS, CCS, risk reduction, risk factor modification, residual risk reduction or modification, host factors, and most of the clinicians are in this loop. ACS, CCS, ACS, CCS. Very few of us realize there is a way out from the CCS, that is elimination of atherosclerosis. So when we talk of atherosclerosis, the aim is not a reduction of MACE. The aim is regression of atherosclerosis, and that's why you need very, very aggressive lipid lowering. This is a slide I took a photograph in ESC this year, and this is Patrick Sarayas, who know him. Many of us know him as a hardcore interventionist, and his projections for 2040 is pharmacological revascularization is the aim or likelihood in future. So ladies and gentlemen, you have to think beyond MACE, that is regression of atherosclerosis, and that is how I set the context of my talk, why we need these agents. This is an editorial by Professor Braunwald, Race to the Bottom. In fact, we are trying to reach the bottom of the bottomless pit so that we regress atherosclerosis. Many of you must be aware how the ApoA1 Milano came. It has a genetic basis. Then many of you must know loss of function of PCSK9 resulted in longevity of life. Many of you will know that SGLT2, loss of function of SGLT2 gene resulted in a condition called normoglycemia with congenital hyperglycemia. And that set the background of SGLT2 inhibitors. And ladies and gentlemen, talking yet another thing which is same, that CT is Ashkenazi Jewish longevity project, where a lady was identified that she has loss of function of CETP gene with supercentenarian age. So that is the background. You have to understand little bit of genetics and statistics now in every disease, because that sets the tone of our future discoveries of drug. If you look at the animal kingdom, most of the animal kingdom is blessed with high HDL level. It is only humans who have LDL-C and atherogenicity. CETP is nothing but a protein which is secreted by the liver, and it does what it does. It causes bidirectional transfer of cholesterol esters.
Dr. Rajiv,
Huh?
not moving.
Yeah. No, they are moving at my end.
No, not to our end.
Yes. Yeah. Can't you see? Can you see my slides now?
What slide is there? You click on.
There's the same lady at 112, nothing
Dr.
beyond.
Rajiv, click on this slide and then it will move. Click on this slide and then next slide. Now next slide.
Yeah. Yeah. Thank you.
No, it's not seen.
So this is most of the not seen.
Just next slide, put 2-3 times.
Yeah.
Not,
Could you see now?
no.
Could you see now?
But they are not moving.
No, same slide.
Same slide. You can stop
Now?
sharing, you can share then.
Okay.
Not
Okay.
moving.
Okay. Now you can see.
Not yet. Now just move. Slide. Now it's moving. Now it's moving.
Okay. So most of the animal kingdom is blessed with high HDL level. It is only humans who have high LDL level, and probably that is the cause of atherogenicity. CETP proteins is secreted by the liver, and it has got a bidirectional transfer of cholesterol esters and triglycerides between all plasma proteins. It's not HDL and LDL. And this is a very simple photograph I could take out. Liver is the central station, and we have two bogies, HDL bogie and LDL bogie. And the LDL moves into the organs and arteries, and then it causes atherogenesis. Then you have a reverse cholesterol transfer. Some of it is taken by HDL. And here is the CETP. There is a crosstalk between LDL and HDL. Cholesterol esters is being transferred from HDL to LDL, and triglyceride is being transferred to HDL. And these bogies, they go to liver and present again to the liver through LDL receptor, and HDL again takes the cholesterol through SCB receptors to liver. So that is how many of us feel the regression of atherosclerosis is reverse cholesterol transport by HDL. No. The LDL also participate in reversal or regression of atherosclerosis by CETP. And that is how you can look at, there can be crosstalk through CETP between HDL and VLDL, VLDL and LDL, making it very small, dense LDL particle, which is rich in cholesterol, which is rich in TGs, and that is how they become very, very atherogenic. Because of their small size, they can pass through the gap junctions. The mechanistic pathway is shuttle mechanism, that the cholesterol esters, they pass on to the other protein through the shuttle or tunnel mechanism when the two particles are joined together. Then we have genetic understanding that CETP in various genetic models is not only associated with higher HDL-C, but concordant lower LDL-C and ApoB, and probably that gives us the protection. The protection given by LDL lowering of CETP inhibitors is exactly same as that of HMG, PCSK9, and PLC. So what I'm trying to emphasize, unlike HbA1c, the LDL-C is a quantitative reduction, not a qualitative reduction. Whatever is the mechanism, including bariatric surgery, the percentage of LDL reduction matters, not the method or the agent with which you reduce. So that is a very, very basic fundamental difference between LDL and HbA1c. This is once again talking simple genetics, that the initial CETP trials, they all failed because they had no effect on LDL-C. Number two, the torcetrapib increased the BP off-target actions and was not found to be effective. The trial duration was long, but when we study the new variants, it both reduces LDL and increase HDL, and it is a lifelong experiment. And this is how we came to know that there are different agents possibly which can decrease LDL and increase HDL, and that may result in change in our understanding of atherosclerosis with CETP inhibition. More the potent CETP inhibitor, more is the efficacy in ASCVD risk reduction. When quartile 4 is more efficacious than quartile 1. The another very important thing is the CETP inhibition and PCSK9, they are additive. They both reduce LPA, they both reduce LDL-C. So when you have higher levels of CETP and PCSK9, you have highest risk. When you have both lower level of CETP or PCSK9, or in other words, CETP inhibition and PCSK9, the risk reduction is maximum. So these agents are supportive, they are not conflicting and competitive. When the CETP inhibition is done, it decreases hepatic cholesterol, resulting in upregulation of LDL, and that's why the LDL level also goes down. I'm going to give you some insight that CETP inhibitors should not be seen as HDL raising drug. They should be seen as HDL raising drug along with more powerful effect on LDL lowering. This is the trial of all the drugs. Torcetrapib failed because of off-target side effects. Delcetrapib, you can see hardly any effect on LDL-C, hardly any effect on ApoB, but it decreased the onset of diabetes, and the trial was terminated for futility. If you look evacetrapib, again LDL-C reduction was modest. The ApoB reduction was not there, it increased. And that's why it resulted in futility. Again, two important things came out: consistency in diabetes mellitus reduction and decrease in LPA. Anacetrapib, a revealed trial, reduction in both LDL-C and ApoB, reduction in MACE. So ultimately, CETP inhibitors work with the same mechanism as other LDL lowering, ApoB reduction, and the reduction in LDL-C. What we found, again, consistency in diabetes mellitus reduction and LPA reduction. So this is just a broad layout, and we have a new drug which is powerful in reducing LDL, and this drug has been the point of interest at the moment. Rest of the trials I have shown you, they had not been positive, and in fact, delacetrapib not only fail to reduce ApoB, but increase CRP. So these drugs are out of market now, but set the tone that we are missing something, and that's why obicetrapib came. Obicetrapib is a new CETP inhibitor. It is hydrophilic and not like anacetrapib. It is not deposited in fatty tissue. It has got a faster clearance. And just to put you across a simple holistic view, obicetrapib is the most powerful CETP inhibitor and may reduce LDL almost by 2 millimoles. So this is why this drug is point of interest. And there are several trials, the ROSE trial, which is monotherapy on top of high intensity therapy. And you find that the LDL-C percentage reduction is dose related, 5 milligram, 42%, obicetrapib, 10 milligram, 51%. If you calculate it, this is again 43, 46%. ApoB reduction, again 30% ApoB reduction. Notched LDL-C reduction, which was talked by Dr. Piyush, 44%. LPA reduction, 34%, 57%, TG reduction, 11 and 8%. So everything matches the way we think LDL lowering should work. LDL lowering associated with TG reduction, LDL lowering associated with LPA reduction, LDL lowering with non-HDL reduction, ApoB reduction. So obicetrapib is in a way is a very ideal molecule. Coming to the ROSE-2 trial, this is agitamide is added. So the first ROSE-1 trial was high intensity background obicetrapib, while ROSE-2 trial is obicetrapib agitamide. And again, we had the same data, almost 63% reduction in LDL. That means this patient is on high intensity statin, agitamide, and obicetrapib. So 63% reduction, non-HDL-C 55% reduction. And this is what you see, overall change from baseline. And if you look at that, the drug in different baselines were on top, 42% patient became with 10 milligram at less than 55, 87 with became less than, when you use 10 milligram of obicetrapib and agitamide rose to 87% achieved less than 55. So it's a very, very good combination. Another things which you have to understand is LDL particle size, although Dr. Piyush was not happy with the particle size, but I am very concerned about small LDL particles. They are like LDL bullets. Their size is so small, they pass through the gap junction, not through the transcytosis. And the only drug available today to reduce a small LDL particle, which is the problem in diabetic patients, is obicetrapib, because it reduces small dense particle. It increases the size of LDL particle. As the size becomes bigger, they become less atherogenic. LPA reduction, it is nanomole, as talked by Dr. Piyush, 10 milligram, 47%, and obicetrapib is 40%. So this is a drug which is giving us add-on value on LPA. So if I summarize, with 10 milligram obicetrapib and ezetimibe, everything is favorable, and you have 95% reduction in a small dense LDL particle, which is not done by any other drug. So this is a summary, and it shows that this drug is going to have a big future. The side effect profile is very, very safe. There are hardly any side effects. The mechanistic pathway is very, very simple, that it causes CETP inhibitions. And this is again a transintestinal cholesterol exocytosis. So this also causes, in a way, that these drugs, they cause exocytosis of cholesterol particle, so that they have additional transintestinal cholesterol excretion. So this is another mechanism beyond CETP inhibition, that they work on intestine and they have effective coexistence with ezetimibe. As I showed you, the consistency in diabetes reduction, which is very, very important, because we know the high intensity statin is diabetogenic. You know that higher in FH, higher incidence of diabetes. If you have loss of function of this, then you have low diabetes, low LDL-C and pooled risk score. This is genetic risk score. If both are low, then the incidence of diabetes. So LDL, high level of LDL in a way are diabetogenic, while this drug reverses the trend. There are upcoming trials, Broadway, Brooklyn, Prevail, and Tandem. The trial Rose 1 and Rose 2 are not outcome-based. They are biochemical trials suggesting that this drug has a favorable effect. Michael Davidson is leading the obesity trial series. This is the layout of the trial. We are waiting for CVOT outcome trials, like I asked Dr. Manoria about the outcome trials of tirzepatide. So we don't have an outcome trial, but the drug works very well on all over the lipid profile. This is a top line data which was presented in December 24, again suggesting that LDL-C reduction is very, very effective to the tune of about 30%, 30 to 40% in majority of the patients. They have non-cardiac benefit, as I showed you, reduction of new onset diabetes. If we take all the trials, roughly about 16% reduction in new onset diabetes. CETP inhibitors are also useful in neurodegenerative diseases. So ladies and gentlemen, I'll summarize that CETP inhibitors are no longer seen as HDL raising drug. They effectively modify favorably the lipid profile by reducing LDL-C, by reducing LPA, by reducing ApoB, by reducing non-HDL-C, by reducing CRP. So these drugs are very, very effective, and we only lack right now is the outcome trial. So when we aim of regression of therapy, I think the future is bright, because these drugs will be oral drugs and they will effectively modify the atherosclerosis. I'm sure I have been able to implant some thought in your mind through your ears, because if we have a conception of hearing, naturally it blossoms over a period of time. We should not be too busy for improvements. Like this gentleman is not interested in listening because the other one is giving him wheels. So CETP inhibitors are new wheels in lipid modification. We should not overlook them. And this is the last slide of my presentation. If you want to become different, you have to do things different. If a cat that dreams of becoming a lion must lose its appetite for rats. If you want to change atherosclerosis, if you want to aim the regression of atherosclerosis, you have to think differently beyond MACE reduction, and you need newer agents. And I think CETP inhibitor is a hope on shelf, and soon we should be able to modify our lipids better to eliminate atherosclerosis. Thank you very much.
Dr. Rajiv, many of the drugs talk about stabilization, but few drugs talk about regression. Is this the only one that results into possible regression?
No, the regression is not agent specific. Regression is LDL level related. As I told you, unlike diabetology, HbA1c, how you reduce it matters. Glimepiride reduces HbA1c and GLP-1 receptor. They are different. But in LDL, what matters is the quantitative reduction. Whether you reduce it by bariatric surgery, whether you reduce it by PCSK9, whether you reduce it by inclisiran, or you reduce it by combination of bempedoic acid, ezetimibe and statins, or whether you use it by CETP inhibitor. So the bottom line is, it is the quantitative reduction of LDL, not the qualitative reduction as we see in HbA1c. So that regression is not molecule related.
Thank you.
Sir, nice presentation. And sir, you continue, sir. Sir, continue.
That's
sir, please
fine.
continue.
Sir,
you continue, please.
Against the backdrop of inclisiran, where do you place it?
There is no backdrop of anything. In lipid warfares, anything which is cheaper will take over. Because if this combination is cheaper than inclisiran will disappear. Because there is no advantage of PCSK9 or inclisiran if you have comparative LDL reduction with other drugs.
Dr.
It's
Rajeev,
very categorical.
No, it is a fact. It is a fact.
Dr. Rajeev,
Yes, sir.
why all trials of pharmacological elevation of HDL has been flop trials? Your viewpoint on this?
I can't say, because these trials were shorter duration, and HDL-C increase was, you see, if you have a bus already loaded with garbage, you keep increasing these trucks. They were not scavenged. The levels were raised, but they were not scavenged. Unless you scavenge the HDL, and HDL is no longer a risk factor modification in any of the pharmacotherapy, because HDL increase, people say, is a bystander of the product. If you have epidemiologically increase in HDL within a limit, HDL has got a U-shaped curve. We thought it is a linear curve. If you have too low HDL, if you have very high HDL, both are problematic. So the functionality of HDL changes at very high level, because all these drugs, they increase HDL by 100%, 150%. So functionality is very important. LDL is more like a gentleman. If he is a rogue, if he is a criminal, he behaves the same way. LDL is not deceptive. LDL behaves the same way, while the functionality of the HDL changes with the blood levels of HDL.
Very true, Dr. Rajeev. Just one second,
Yes,
Dr. Vijan here.
no.
In fact,
Yeah.
when we had reviewed this HDL, it is a U-shaped curve. For the sake of audience, you also mentioned that the lower the LDL, the better, and the cheaper, which is going to be in the long run.
Yeah.
So make a mention about the triple combo, because we are talking of the outcomes. In this limited trial, whatever we have had, even in the acute infarct setting, we had a very low mortality. Could you throw a light for the audience? Triple combo.
See, triple combo, I was one of the authors, and the Lipid Association of India, Dr. Bejan, we all were there. We got awarded the Paul Dudley White Scholar Award for that trial, because what matters is how early you hit, how long you hit, how cheap you hit. That is the key in lipidology. It should be cheap, because I always tell my colleagues, don't invest money in nicorandil, sorbitrate, and flavidon in the chronic coronary syndrome. They do not breed anything. Invest patients' money on lipid modification. What flavidon will do, what nicorandil will do, a patient who is painless, what they will do. So we should stop putting these toppings on the prescription and invest patients' money on a very, very aggressive lipid lowering. Majority of my patients are maintaining total cholesterol less than 100 and LDL of 10, 15, and 20. I endorse your views. Earlier you do, aggressively you do. We have to disconnect from another idea that lipid modification only works in long term. It works in acute settings also. We have had OCT images, NEEDS images, where lipid core has just disappeared in 4 to 6 weeks. So I fully agree with you that aggressive triple combo on day one in ACS is the way to go.
Very early hit hard.
Dr. Rajeev, although not directly related to the topic, what is the effect of alcohol on HDL and its subfractions? Once we are talking of HDL.
They do increase, but there is no protection. Alcohol is now no longer seen as a protective thing. And the advisories are that if you are not alcoholic, don't start alcohol, understanding that it will increase the HDL and that will be cardioprotective. That saves us a lot of money for conference organizers who had to serve booze in the conferences. So no longer it is needed. And now I'll only say that HDL story at the moment has gone. We have to disconnect from HDL and focus on LDL. If we have outcome data on LPA, which it should be because it contains ApoB, I'm sure the next future will be aggressive LDL lowering along with LPA reduction. HDL is out of focus now, sir.
Sir, you did
Functionality
touch.
is very,
Yes, sir.
very important.
Sir, you did touch a small LP and ApoB. What is the level of LDL you want to keep?
There is data, 4-year data, where they have shown event reduction up to 10 milligram of LDL. We don't have data regarding single digit LDL, 5, 6, 7, 8. That we don't have data. But 4-year data shows there is incremental benefit in terms of risk reduction up to 10 milligram of LDL. And there is a very important paper by Dr. Amit Khera, which was published in Circulation. He talked that we should talk to our patient, South Asian ancestry and age less than 50 years. The aim should be 10 milligram LDL. That is the paper. Anybody who wants to have that paper, I can pass on. So I am very, very aggressive for LDL, that most of our patients, 60–70% of our patients are less than 50 years. Why should a 30-year-old guy should have a LDL of 40? There is no need, absolutely no need, because we have to aim not reduction of MACE, we have to aim regression of atherosclerosis, and the regression starts less than 55. So in fact, I'm writing a paper, a time has come, unification of lipid goals. You don't need this 70, 50, and 100. This is nonsense. What you need in a young patient, an LDL of 10, 15, or 20.
Thank you, sir. Thank you. Sir, over to Dr. P C Manoria, sir.
We pass on to the next session, and I hand over the mic to Dr. Sajid Ansari and Dr. Vashini to conduct the next session, which is by Dr. Ashish Nabar, the renowned electrophysiologist and ECG specialist.
Good morning, sir. After these very interesting and informative talks, now we will discuss very important drugs in the treatment of various atrial and ventricular arrhythmias. The drugs quinidine, flecainide, sotalol. They are all here. Relearn them with Dr. Ashish Nabar, a senior intervention cardiologist from Mumbai. Dr. Navar.
Yeah, good morning, everybody. Am I audible and is my screen visible?
Yes.
Okay,
Yes.
wonderful. So I'm dumbfounded by Dr. Agarwal's talk, and even last year I think I followed him. It's extremely interesting and very forceful and educated talk. I love to hear that. Thanks very much. So this is kind of a little change from what the story was in the first 3 talks, and we are discussing some antiarrhythmic agents. They are not necessarily so new, but maybe a little new to the Indian practice here, and I'll kind of elaborate a little bit on them. Now, thanks very much, Dr. Manoria, for this invite. I have always loved to be part of Dr. Manoria's CMEs. Now, when I have to talk of these 3 drugs, first we must name and shame amiodarone. Yes, amiodarone is a very, very useful drug. It is used both in supraventricular and ventricular arrhythmias, but there is a need to monitor what dose you are using and take care of any adverse reactions that might be happening. You can't have this patient lost to follow-up, or you cannot be comfortable having started amiodarone in a 50-year-old paroxysmal atrial fibrillation who might need to take it for next 25–30 years. So the reason is that there is a very high discontinuation rate of amiodarone, and that's because of the well-known reasons. You can most commonly have thyroid problems in both directions, hypo or hyperthyroidism. You can have lung problems and also liver problems. So all that needs to be monitoring, and therefore amiodarone is not always or should not always be a knee-jerk reaction and a drug to be used in any setting. And therefore, there comes the role of these 3 agents. Now, let's understand the action potential. If you look at the phase 0, there are drugs which slow the phase 0 and therefore act by prolonging the conduction velocity. These are sodium channel blocking drugs. And there are drugs which block the potassium channels and therefore prolong the action potential, thereby prolong the refractory period, and that's how they either terminate or prevent the recurrence of arrhythmias. So to put it in context of this talk, quinidine is a class 1A drug and flecainide is a class 1C drugs, both acting on the fast sodium channels, affecting the phase 0 of the action potential. On the other hand, you have sotalol, which is a class 3 drugs because it is a potassium channel blocker. So it prolongs the action potential duration by prolonging this phase 2 or phase 3. Now let's go one by one over quinidine. Now people who have practiced since before 1990 know these drugs well. The younger generation not, because this drug was almost not available in the market for a long time, and that's because its use had gone down significantly officially also. Today, this drug is repurposed and it is used to prevent ventricular arrhythmias, which can lead to a sudden cardiac death in certain primary electrical disorders. And I have named them here on the right of the screen. If you see the idiopathic ventricular fibrillation, Brugada syndrome, short QT syndrome, and early repolation syndrome. All these primary electrical disorders are responsible for a polymorphic VT-VF, which can cause sudden cardiac arrest. And that's where quinidine has found its role, largely to the work of an Israeli cardiologist, Dr. Belhassan. And then it can be used selectively in an electrical storm in the setting of structural heart disease, and I'll allude to that soon. So what is quinidine? It is extracted from the cinchona bark, and actually of the 6 alkaloids from the cinchona alkaloids, 3 have been studied: quinine, quinidine, and dihydroquinidine, all of which can be used as antiarrhythmic drugs. And actually before 1990, as I said, almost we didn't have too many antiarrhythmic drugs at that time, and therefore 45% of the US prescriptions of antiarrhythmic prescriptions were using quinidine. So that was the favoritism related to quinidine, to the extent that it is now available in only 15% of the countries worldwide. Now, this drug has a very rapidly reaches the peak level, is excreted within a few hours, and has largely a hepatic metabolism. It acts better when the heart rates are faster. That's called as use dependence. And when you use this drug, you have to monitor basically the QRS width and the QT. It does not have an effect on the PR interval. But there has been a decline in interest after the 1990, largely due to the pro-arrhythmic effects that can lead to deaths, but also because of the day-to-day problem of the GI side effects related to this drug. So almost to the extent that these drugs were removed from the guidelines of SVT. So quinidine was largely used as a drug for SVT, but it fell out of favor. But I think it is important to reintroduce this drug in our practice, because for the primary electrical disorders that I mentioned, the ideal treatment is, of course, an ICD, and in some of them an RF ablation. But the access to ICD is not uniform in a varied geography like ours, and therefore quinidine does have a role, and I'll deal with it soon. Now, this quinidine, for the sake of some of you, is now re-available in the Indian market by these various names: Curide, Quinhart, Natcardine, and it is, you can source it from our pharmacies. Now let's come to idiopathic ventricular fibrillation. Actually, acute coronary syndrome or post-infarct LV dysfunction is the most common cause of sudden cardiac arrest. But at least 5 to 7% of times, the VF is idiopathic in nature. And if you take the younger lot, say less than 35 years, almost 29 to 40% cases are idiopathic ventricular fibrillation. And what happens there is a PVC comes with the R on T, and it can lead to a monomorphic VT or a polymorphic VT, as in this slide, leading to an idiopathic VF, degenerating to idiopathic VF and a sudden cardiac arrest. So before you call idiopathic, it is important to have worked up this patient very well, because there are a lot of causes that are now discovered in addition to coronary syndrome. And therefore, what you do in most of the times is you do an angiogram, you do an MRI now more and more, you do an exercise test to rule out a catecholinergic polymorphic VT, you do a sodium challenge test to rule out Brugada. So you work up this patient extensively, and maybe these days you do also an electrophysiology study or a genetic study before you label something as idiopathic VF. But that apart, when you call it idiopathic VF, the recurrence rate of such a survivor is very high, 10% risk of recurring VF in the next 2.5 years. And therefore, Belhasan is the person that I said who studied this drug and said that people who were given quinidine after an idiopathic VF, if they were studied electrophysiology study, there was non-inducibility, they had no VF recurrence for 15 years. So that is a pretty long time. And there was a Canadian registry which showed that after these patients received ICD, there was a reduction in ICD shocks. So quinidine does work in idiopathic VF by suppressing the Purkinje PDCs. And therefore, the European Society does recommend it to reduce the recurrence of ICD shock. So ICD does remain the treatment of first choice, but quinidine will have a role when these shocks recur and happen too frequently. Now, many of you have seen the ECG and known what to call a Brugada ECG. The ECG, the type 1 Brugada pattern with this convex-like ST segment elevation is the one that is most prone to the risk of sudden cardiac arrest. The type B with a concave ST elevation and the type 3 are a little dubious in terms of the risk of sudden cardiac arrest. Now, what quinidine does here is it restores the hump of this action potential, which is there in the Brugada syndrome, by blocking the ITO current. So this is normalized, and that is how it reduces the VF or polymorphic VT recurrence. So once again, we turn to Belhasan studies who showed that the only few patients out of his 96, only 2 of his 96 patients on quinidine had a recurrence of VT VF. So that is magnificent results. What he advises is use a lower dose because of those GI side effects, and that gives you a better compliance. So therefore, quinidine is again indicated in Brugada syndrome. Well, sometimes it is not possible to implant ICD, which is of course the first choice, or the patient refuses, cost constraints or refusal, then the way to go is to quinidine. Or if sometimes patients are given ICD but they have recurrent ICD shocks, then quinidine will reduce your VT storm related to these recurrent shocks. The third indication is early repolarization syndrome. Now, early repolarization changes in the infralateral leads are the ones to be seen carefully. If you have an ST elevation which is concave up, this kind of early repolarization, this is more likely to be a benign. You often see it in your overwriting ECGs that you do for insurance purposes maybe, or for job fitness purposes. These ones tend to be benign. But when you have an ST elevation which has this kind of a J point elevation and a flat horizontal ST segment elevation, especially if you see such a ECG after a resuscitation from a sudden cardiac arrest, then this is a malignant early repolarization. So a long time we took early repolarization as a relatively benign scenario, but if you see this kind of early repolarization in the flat ST segment, and more so if it happens after resuscitating from a sudden cardiac arrest, then it is an important matter, and these patients have a high risk of recurrence. So almost 41% risk of recurrence in the next 4 years or so. And therefore, once again, here, quinidine is recommended as an adjunct to ICD. So once again, remember, quinidine does not come in place of an ICD, but is useful when ICD cannot be implanted for cost reasons or patient refusal reasons, or when there are recurrent arrhythmias leading to ICD shock. That's where your quinidine, in fact, gives even complete resolution of symptoms. So therefore, quinidine is the drug to go when the ICD is not possible in these 3. And there is also a short QT syndrome, which I'm not dealing with because very few cases world over are recognized as short QT. So these primary electrical disorders, which can lead to polymorphic VT, VF, risking a sudden cardiac arrest, quinidine is your new repurposed drug to take care of that. Now, many times you have an electrical storm in patients who have cardiomyopathy or post-infarct LV systolic dysfunction. When 3 such episodes happen within 24 hours, it is an empirical definition of an electrical storm. Now, quinidine could diminish the survival after ventricular arrhythmia. So they are not the first drug to give on a regular basis, like you use Cordron to suppress ventricular arrhythmias in patients with structural heart disease. But many times you have an electrical storm. You have done amiodarone, you have done Mexoar, Mexiletine, you have sedated, ventilated the patient, tried to use beta blocker if possible, and still there are recurrent shocks. Now that's where, remember, quinidine might help, because in these situations, whether the recurrence is of a polymorphic VT particularly, but also when it's a monomorphic VT that is recurring in these patients with post-infarct LV systolic dysfunction, quinidine can help to quell the VT storm. So remember, a very niche use, not as a first-line drug, but as a very niche use when you have these recurrences that you can use quinidine. And this comes out of some evidence. Here is a reappraisal published in JACC-EP, a very respected journal, which shows that the total number of storm events as well as the total number of ventricular arrhythmic events decrease after quinidine, and does not matter both monomorphic VT as well as polymorphic VT, we have tend to decrease when you have kind of use quinidine in this back against the wall kind of a scenario. So therefore, use it for a short term as this publication concludes, but remember to use it when your combination of amiodarone and mexiletine has not working further, or there are recurrences even after ablation in this setting. Now we switch gears to discuss the other two drugs, flecainide and sotalol. And the reason we switch gears is because those two drugs are largely used for supraventricular arrhythmias. And by and large, there I mean atrial fibrillation. As you know, the other supraventricular arrhythmias like AVNRT or AVRT related to the axis pathway are very well treated by ablation. So long-term use of drugs probably is not required in this setting. Atrial fibrillation is the Achilles heel of arrhythmology. And now let us say you have two ways to deal with atrial fibrillation. Just a quick recap. Either you can do a rate control or you can do a rhythm control. Where do you prefer to restore and maintain sinus rhythm? This is when the patient agrees for the same, when he's a young guy, when he has a shorter history, and where he is symptomatic for the atrial fibrillation. These are the patients where you should think that rhythm control would be a better option. Are there some other markers? Yes. Sometimes you may think that you have tried to do rate control first and the patient is still symptomatic or remains in heart failure. Then you want to switch to rhythm control. That's when you should use. When you have a smaller LA, the chance of maintaining sinus rhythm is good. When you have a tachycardiomyopathy, which can lead to LV systolic dysfunction or say a mitral valve regurg, then these are the situations where rhythm control is to be preferred. Now, how do you do rhythm control? And when to use flecainide and sotalol, which is the main aim of this presentation. So flecainide is actually a use-dependent drug, which means that the ability of the flecainide to convert AF to sinus rhythm is better because it acts better at faster heart rates. Whereas sotalol has a reverse use dependence, meaning it's more effective at slower heart rates. So therefore, the ability of sotalol to prevent the sinus rhythm from going into AF, thus preventing an AF recurrence, is more effective. So this is the difference that you must remember in their properties. Flecainide is use dependent, sotalol is reverse use dependent. And in general, flecainide is a more effective agent than sotalol. Having understood this, let's see what the trials suggest and how to use these drugs. Now, clearly, when you have a patient with a paroxysmal AF and you want to prevent the episodes, you can turn to these drugs. But the most important thing here is there has to be no important structural heart disease. LV ejection fraction is normal. The CAST trial has really scared us to use antiarrhythmic drugs in the setting of an important structural heart disease. We have generalized some of the results of the CAST trial to avoid proarrhythmia. So therefore, when you have an atrial fibrillation with a minimal heart disease or a completely absent structural heart disease, then you can use flecainide or propafenone. So don't jump to cordon in this setting is the moral of the story. So you can use flecainide, which is a class 1C drug, propafenone, also class 1C drug available to us. So this would become your first choice. When that fails, you can use sotalol. Whereas when it comes to people with mild kind of a structural heart disease, a mid-range heart failure with mid-range ejection fraction, then your amiodarone does become the first choice, but sotalol is possible to use. So flecainide, propafenone, a PAF patient with no structural heart disease at all, whereas with a mild structural heart disease, you can use sotalol for treating PAF. So remember, that is the strategy when you're dealing with paroxysmal atrial fibrillation. Now, this choice actually does not differ when you are dealing with persistent atrial fibrillation. Mind you, all this comes from very recent guidelines. So when you have a persistent AF, it is not good enough, as most people do, to start flecainide or sotalol and wait for sinus rhythm to come. That's not likely to happen. 20-30% chance of getting sinus rhythm when your atrial fibrillation has already been for so long. And therefore, you must cardiovert. Now, this step is not easily taken by many physicians or for that matter, cardiologists. because there is some kind of aversion from our side as well as the patient's side to electrical cardioversion. Unless you electrically cardiovert, it is not fruitful to just keep on giving antiarrhythmic drugs. So persistent AF, electrically cardiovert, and then the same rule applies. If you have a minimal or absent heart disease, you can use flecainide. If you have mild heart disease, you can use sotalol. Once you start going on the side of heart disease, yes, amiodarone is your go-to drug. Clonidone, I think, is not available to us. So therefore, this is the difference in the strategy when you're dealing with paroxysmal or persistent AF. Just a bit detailing with the use of flecainide. Importantly, you have to watch for the renal function because it's a renal excretion, and with the renal dysfunction, you will have difficulty in using flecainide. You have to use a AV node blocking agent along with. That's because many times atrial fibrillation converts to flutter, the heart rate goes very fast. If it goes 1 to 1, patient gets extremely symptomatic. Your beta blockers would try and prevent that. What do you monitor when patients on flecainide? QRS width is more important than the QT. So if QRS width increases more than 25%, it is suggestive of toxicity. You have to cut back the dose. Of course, you will monitor for bradycardias when you are using any antiarrhythmic drugs for that matter. So these are some of the things that are important when dealing with flecainide. We don't have in this topic the discussion of propafenone, but both these drugs are class 1C drugs, and importantly, both of them are available in the Indian market. So you should know when to use them. More importantly, not to use them in the wrong indication. Does flecainide have some more use? Yes. There is something called as a Brugada challenge test. Now you have a patient with syncope and a ECG which looks like this, which you will call a type 2 Brugada. And I told you type 2 Brugada is not very associated with the risk of certain cardiac arrest, or you may have a ECG like this where there is a right bundle branch block, but you may call this as a type 3 Brugada. So type 1 and type 2, you do not know whether to ascertain, whether to conclude that the syncope is coming from a Brugada, and therefore you need a flecainide challenge test, which routinely is done by using intravenous flecainide. We may have it sooner, but presently we do not. So there is this publication from C. Chitra, which used oral flecainide and monitored the ECGs frequently thereafter, initially 5 minutes, then 30 minutes for 4 hours. And if you get a positivity, which is suggestive of a type 1 Brugada on the ECG, then you have diagnosed a Brugada syndrome. So therefore, it is used as an oral flecainide challenge test. Lastly, with sotalol, sotalol is slightly different. It is a potassium channel blocker, and therefore the action potential duration and therefore the QT interval will prolong. And obviously, that is what you need to monitor. Again, a drug which has a renal excretion, so you will have some dose reductions when you have a patient with CKD. At lower doses, it's more of a beta blocker. At higher doses, it is additionally a class 3 antiarrhythmic drug. But over the dose of 320, you have to be careful. The difference between flecainide and sotalol is that sotalol can be not only be used for atrial fibrillation in different forms, like paroxysmal or post-operative fibrillation, but you can also use it to suppress PVCs in the absence of structural heart disease. Some of these PVCs can be ablated very well, but when they are too few but symptomatic, or when you haven't succeeded in ablation, then sotalol can help you to suppress those PVCs. Do not use Cardron here unnecessarily. Again, it is used in some fetal supraventricular arrhythmias, and these days SVTs are generally ablated. But if there is a refusal from the side of the patient for whatever reasons best known to him, then sotalol can help you more than some of the simpler drugs that you normally use. So I think I'll conclude here. What I need to say is that quinidine has been repurposed to use in some primary electrical disorders, and just to name them once again, it is early repolation syndrome, Brugada syndrome, short QT syndrome. These are where it is used more. Idiopathic ventricular fibrillation is an important diagnosis. So and it is a back against the wall drug when you're dealing with a VT storm in structural heart disease. Flecainide is a drug for paroxysmal or persistent AF in absence of structural heart disease. Very important. Sotalol is a drug which can be used for AF, but also to treat some ventricular arrhythmias. And you can use when you have an ejection fraction above 40. So even with mild LV systolic dysfunction. So I think I'll stop here. And if there are some questions, I would be glad to answer. Thank you once again for your very patient listening. And happy Republic Day to all of you.
Dr. Ashish, thank you very much. Guide me how to choose between flecainide and propafenone for a non-electrophysiologist like me, which is the step one, because both are class 1. So how do I do?
So it is not really a great thing to decide. we use flecainide more because it is because there is a little bit ease of its availability. That's number one. Propafenone, the additional benefit is propafenone has more beta blocker action than flecainide. So when you are additionally hoping to control the ventricular rate in case of a recurrence, propafenone is a slightly better drug. Unfortunately, the availability of propafenone in our country can vary a bit, and these patients, as you know, are on long term, and you do not want them coming every 4-5 months back to you saying that this is not available easily. So therefore, flecainide tends to get used a bit more. Essentially, they are similar, except one fact that propafenone has a little more beta blocking action also.
Ashish,
Thank
just
you.
some
Thank you.
few question.
Yeah, sure.
With the permission of chair.
Please.
One is that you mentioned, early repolarization syndrome is so often even with the auto ECGs. And we always keep on telling, at the physician level that, look, this is a benign condition. So now with this, of course, you have mentioned that if it is a flat type rather than the convex. So would you want to investigate all types of, early repolarization ERS? That is one. Second thing is when you wanted a beta blocker activity, can you use a combination of flecainide with sotalol? Thereby, they can negate each other's effect. And a third thing was that we mentioned that you have to look into LV ejection fraction. Nowadays, when we are talking of supraventricular arrhythmias, it is not the pump but the pre-pump. And often you see a very early changes you see on echocardiography. You find the LA volume is on the higher side. The LA ejection fraction, even LA-GLS, the cutoff point is 33 to 35%, even the EF. These are the ones which are impaired. So would you then still call it as a normal structural heart? Because most of the time, with the simple things like echo, with at least a 4D, you can pick up these anomalies.
Yeah, obviously all great
Dr.
questions.
Dr. Ashish, I'll put a supplementary. Can we use a combination of flecainide Corderol so that you can answer all in a row?
Right. So the first question was with relation to the early repolarization. Now, a few points to take home here is, as you rightly said, Dr. Vijan, early repolarization is seen very often or seen incidentally when the ECs are made for, say, pre-employment or for whatever, underwriting for a LIC purpose or whatever. And you don't start disqualifying these people. Whom would you not disqualify? One is if you have those changes in the precordial leads, say V1, V2, V3 are surely early repolarization, whereas infralateral leads, you're going to look at that morphology, which I mentioned. So one thing is that. The second thing is go by the history. If there is a history of any kind of a syncope or palpitations or a pre-syncope, something that we may not always take diligently, but look over this history. And certainly if there is a family history of a premature sudden cardiac death, then that is again a pointer. So it may not be investigating everybody right away unless that guy is keen on some kind of a risky profession, say somebody wants to be a loco pilot in a railways or something like that. Then you might have, but I don't have any provocative test known to be described for unmasking further an early repolarization syndrome. There are provocative tests for Brucada, there are provocative tests for QT, where you can unmask that and say that with more confidence than just an office ECG. For early repolarization, there is not any such, and therefore it is a little tricky scenario, both early repolarization, short QT, whether to immediately start calling them disease. So unless there are symptoms, I wouldn't really call it a disease, or there is probably no way to investigate them further at this point in time. So, yeah.
Flecainide is a good drug for paroxysmal atrial fibrillation without structural heart disease, but it's highly underutilized. What are reasons for this?
One thing is that I think in general, people are a little, for right reasons also, people are a little scared about the pro-arrhythmic nature of the antiarrhythmic drugs. And in that sense, they find Cordron the safest, and probably they overlook its non-cardiac probabilities. But that's one reason. But it's important to understand flecainide as a drug to be used in non-structural heart disease for paroxysmal atrial fibrillation, so not for ventricular arrhythmias. And it's important to look at other things like renal dysfunction. What is the baseline heart rate? So you have a baseline heart rate, a tachybradic kind of a subtle scenario where the sinus rate is say 55 or something, and he gets AF. This is probably not where you would use any antiarrhythmic drug for that matter liberally. So if one understands this kind of nuances involved in. Other thing is the monitoring. It is not the QT, but the QRS width that is important. And once you see that the QRS width is getting a too broader, then that's the time you cut back on the dose. So these are the nuances. Very few, not I guess, not at all a problem for guys who are discussing CETP. I have great difficulty in understanding that, but you know, so if one takes these few things home, one would, I think, realize that one is overusing amiodarone a bit too much. About the combination, I think generally one should avoid combination of the antiarrhythmic drugs because it is not so distinct that flecainide will only act on the phase 1 and therefore only be a QRS prolonging, and amiodarone will only prolong the QT. It's not all. It's the predominant effect which makes them classified into these things. So therefore, a flecainide will also prolong the QT, and amiodarone will also slow the myocardial conduction. So therefore, in general, combining antiarrhythmic drugs is, unless there is a strong reason, not a great thing to do. Avoid that, particularly if you see a renal dysfunction being disturbed. Certainly avoid that because you don't want proarrhythmia for a benign disorder like atrial fibrillation. And again, ablation is underutilized. I mean, despite being an electrophysiologist, I'll say that we are underutilizing the ablation of AF for all the reasons which here I do not want to enumerate. But we will soon have strategies which allow atrial fibrillation ablation to be done in a much safer way, faster way, and a more reproducible way, and the results which can hold on for longer. So, so when we have those kind of possibilities, I think only treating by drugs in a younger person with no structural heart disease probably will take a little back seat. So, so ablation will probably take a front seat in some years when we have better methods to do them.
With tachyarrhythmias, amiodarone should not be used.
Sorry,
tachyarrhythmias, amiodarone should not be used.
So, for atrial fibrillation in a normal structural heart, you should prefer to start one first with a class 1C drug. Sotal, although weaker drug, should be used first. Amiodarone is now relegated to be using after ablation. So it will be a little surprising to use atrial fibrillation in a 45, 50-year-old guy, hoping that he will take amiodarone for next 25, 30 years. So yes, you should not use amiodarone there. VT in structural heart disease, you have no options. Or for that matter, arrhythmia in structural heart disease, you are crippled and you need to use amiodarone. That is your best possibility. So I think that's the structural heart disease is the main crux of when you decide to leave amiodarone or take up to amiodarone.
This pulmonary obesity is, which is very important. What is the incidence in Indian population? And it continues to progress even after you have stopped. How dangerous it can be.
Correct. So, there are two of them. One is acute amiodaronitis, which happens when you, it happens soon after you give high dosage of amiodarone. And the second is the interstitial fibrosis that happens in the long term. Now, yes, we do see them, but we see them far less often than the extent to which we see the thyroid disorders. So I think a DLCO is the pulmonary function test that you should keep doing whenever you suspect. And keeping to a low dose is very important. All said and done, most of the times, if you're rightly starting amiodarone, you would ideally want it to continue. So then keep it at a low dose. For example, you have a patient who has an ICD and you still continue on 400 milligram amiodarone for last 2 years. He has had a no shock. That means you have not realized that one can get off amiodarone because you already have a protection for sudden cardiac death, and you are buying the side effects of amiodarone when actually you can curtail its use significantly in this scenario. So that's just one example where you can, and tomorrow you get ablation, then you are delaying ablation till it becomes not a good option. Again, that would be where you can restrict the use of amiodarone.
Dr. Sajid, any questions or comments?
Yes, sir. Wonderful, Dr. Ashish, and thank you, sir. Dr. Ashish, very one small question. For
Yes.
how long you are educating the amiodarone using chronic atrial fibrillation? What the maximum duration?
Well, it is like this when you, so these days, by chronic atrial fibrillation, I would mean that you are talking of two entities in the current language. One is long-standing persistent atrial fibrillation, where you have atrial fibrillation which is continuous for more than a year. And the last thing is you have permanent atrial fibrillation. So permanent atrial fibrillation is where you have come to a conclusion either by cardioverting 1 or 2 times earlier or by knowing the structural heart that the LA is too large, that that the sinus rhythm is untenable. Now, in permanent atrial fibrillation, obviously you should get off the amiodarone and go to rate control agents only. When you have long-standing persistent atrial fibrillation, then these are again the candidates who are less likely to remain in sinus rhythm with amiodarone, or not likely to have good results with ablation. Now, here you should switch at that time to AV node ablation and doing a pacemaker, which may be either a CRT pacemaker or a dual chamber pacemaker with left bundle area pacing, so that you give adequate rate control, because rhythm control is no longer tenable. And in these situations, if you just keep on using amiodarone, that's wrong. But in paroxysmal and persistent, short persistent atrial fibrillation, less than 1 year duration, where you do not have the option for ablation, where you have the structural heart disease, you are committed to amiodarone, yes, you will use it at a long term. As I said previously, try to reduce the dose. Tronedron was not so effective, and therefore it went out of the Indian market, but it still continues to be mentioned in the guidelines, and in US it's still available. So we naturally have less experience, but it was in those times thought to be a less effective drug. But if you have those kind of side effects of amiodarone and you need to use amiodarone like drug, then maybe you can switch to donadron. Unfortunately, in our setting, we do not have this possibility.
Yeah. Okay. Thank you, Dr. Ashish. Wonderful.
Any comments? Otherwise, move on to the next. Dr. Simitabai, any comments, or move on to the next session?
Yeah, sir. It is a very nice lecture, and my PGs have also joined. I have a quick question, like what we face in our medical ICU. We have patients with acute stroke, and they have a acute onset of atrial fibrillation with fast ventricular rate. So we want to control the rate first. So what drugs will you prefer for this, Dr. Nabar?
You're absolutely right when you said in first instance that somebody has had a stroke and a AFib. Now here you are not trying to do rhythm control, because you may be having a clot in the LA, so that is out of question. That's a very good thing that you have mentioned. First, you are trying to do a rate control. Now, rate control drugs, you have actually 3 beta blockers, calcium channel blockers, and digoxin. Now, these all of us need to re-understand maybe that beta blockers, you will have difficulty if these patients are on inotropes, but certainly they are the drugs of choice because they are the safest. Calcium channel blockers, you have difficulty if the LV function is very low. Beta blockers, again, the difficulty is with an active bronchospasm. And digoxin, you have difficulty if there is a renal dysfunction. But again, they are the choice if you have LV systolic dysfunction. Those are the when not to issues that help you to combine drugs. And here you should probably try to combine drugs, because beta blocker, and again, forgotten art is rapid digitalization. I think it is really forgotten in the 21st generation, century generation. I mean, you can rapidly digitalize when you do not have the when the creatinine is okay, to give that effect of rate control faster. So digoxin with beta blocker, digoxin with calcium channel blocker, depending on what are not the if the contraindications are not there, you can combine these 2 drugs to get a rate control. And again, anticoagulation starting is a separate issue depending on the size of the infarct. You will have to delay the restart of the anticoagulation. TIAs, you may start faster. Large infarcts, you may have to delay for 1 week or so. And your repeat scans will tell you whether you can, there is no hemorrhage in the infarct, and then start. So that's a separate issue. But rate control agent, you're right. You, depending on what contraindications are not there, preferably you may want to combine 2 of them to get a good handle on the rate control. Again, how soon, how fast depends on whether there are additional issues like heart failure that are complicating matters, and you want to have a rapid rate control.
Okay, thank you. Thank you, Dr. Nabar.
For a very informative discourse. So we now move on to the next session, Echo in Emergency Room, by Dr. Sanjay Mittal, a renowned heart specialist and a renowned echocardiographer from Medanta, Gurugram. Hand over the mic to Ashish Malhotra and Sandeep Rai. Dr. Ashish, please initiate the session.
Good morning. Thanks, sir, for giving me this opportunity for this very important session. And now Dr. Mittal is going to speak on the echocardiography in the post-MI scenario. What are the precautions and what we can achieve by getting good echocardiography, and what decision making can change as per a good echocardiography done immediately in the post-MI period or in the emergency room. Over to Dr. Sanjay Mittal.
Thank you, Dr. Ashish. I think, first of all, let me thank Dr. P C Manoria for inviting me to give this talk. It's very important In today's scenario, I would consider that echocardiography is just like a stethoscope. It gives you much more information, specifically in the emergency rooms. But the problem is, when we are talking about emergency room, we have a situation at hand. And that is that we do not necessarily have a cardiologist there. First of all, whenever the person is presenting in the emergency room, it's likely that the condition is critical. And many a times we do not have time to react. We have immediate decisions to be made. Cardiologist may not necessarily be there. So intensivist or emergency doctor has to do the echocardiogram. But it can help in diagnosing, it can help in triaging, and it can help in therapeutic guidance. What is also important is that we have all the nuances of echocardiography, not only telling us the structural defects, but also the hemodynamics. Important is who is performing and what is the legal binding of usage of ultrasound in the emergency room in most of the hospitals. So we have to have PNDT certification in all the ultrasound systems, but nevertheless, an emergency medical officer is going to use it. And that is why echocardiography should be goal-oriented, target-oriented, and be reading into both the things, the structure as well as hemodynamics. Today, many of the intensive cares, ultrasoundists, and pulmonologists also are using echocardiogram or ultrasound for a detection of various heart failure scenarios, pulmonary edemas, pneumothorax, and other things in the emergency room as well. So let me first discuss about what could be the scenarios. When a person is presenting to the emergency room, he is not carrying a diagnosis. He is just carrying some symptoms. And many of the time, symptoms could be drastic and devastating. Hypotension, shock, breathlessness, chest pain, arrhythmia, syncope, stroke, and all these things, echocardiography would come into fore. Let me start with the first kind of scenarios, hypotension and shock. It could be with so many reasons. Cardiogenic shock is the commonest and most dreaded one. But I'll give you some examples. We talk about hypovolemia, we talk about systolic dysfunction, sepsis, pulmonary embolism, tamponade, and post-myocardial infarction complications could all be reasons for the hypotension and shock syndrome. We know how to evaluate the IVC. It will look at the fluid status. Hypovolemia can be diagnosed easily, specifically if the size is small and the person has a collapsing the IVC. But also look at the scenario. There is hardly any left ventricular or left atrial cavity seen. The right ventricular cavity is also small. So if such a situation is there, this is definitely a symptom of hypovolemia, and person would respond to fluids. On the other hand, if a person is presenting with an ejection fraction like this, the RA and RV are full, this is overloaded system, and the likelihood of hypotension is cardiogenic shock, and the treatment should be ensued in accordance to that. Pericardial effusion, which could be a complication of viral pericarditis, tubercular pericarditis, or maybe sometimes post-pericarditis syndromes, could also be things to be looked at. And tamponade, we all know how to diagnose. A lot of variation in the mitral inflow pattern could be definitely diagnostic of tamponade. And a simple draining of this fluid can actually improve the hemodynamics and save lives of the people. And that is what is important for us to diagnose on the emergency table. Pulmonary embolisms, we have lots of signs, but a simple look. Most of the times we are missing out on the opportunities of diagnosing pulmonary embolism early. But a collapsed left ventricle, dilated right atrium and right ventricle with various signs, the McCollum signs, which shows the apex of the right ventricle is contractile, but the lateral wall or the free wall of the right ventricle is not contracting or is almost akinetic. is a suggestive sign that this person might be dealing with pulmonary embolism and should be worked on. We may sometimes look at the pulmonary clots in the pulmonary arteries and all those things could be important. Let me give you a scenario, because when a person presents to the emergency room, it's not hunky-dory. Everything is not very clear. I had this clinical scenario with me, a young gentleman, 36 years, presented with myocarditis heart failure 3 months back and was diagnosed with SIPOD. We actually advised him to put a ICD, and because of monetary constraints, he got ICD implanted somewhere else. And he was put on PPI, he was in cardiogenic shock, counts were elevated, and he, after CRTD, was continued to be in shock and was brought to Medanta in July on ventilator with a FiO2 of 40. He had triple inotropes, and yet the blood pressure was just 80 millimeters of mercury. What is this thing? When we did the echocardiogram, we find the ejection fraction was just 25-ish. Okay. Global hypokinesia, minded, the person was already pre-diagnosed to be having sarcoidosis with cardiomyopathy and elevated systolic dysfunction. But what was important is that if you look at the right ventricle, it is not so dilated as the left ventricle is. Rather, it's a small right atrium and right ventricle. And this person was receiving triple inotropes. So what we did was we looked at the other parameters, and the biggest challenge was the mitral inflow pattern was A, which was taller than E wave, suggesting that LV and systolic and filling pressure was not high. And what also we find is that when we look at the IVC, it was all collapsing. So many times situations like this do happen, that we are foxed by just one side of the story, that the person has a very poor systolic function, and this is likely to be a candidate for cardiogenic shock. But we forget that things could be mixed patterns, and this person, we just gave IV fluids, tapered down the inotropes, and the person is touch wood doing well. We have already 6 months follow-up of this patient. And later on, we found that there was dengue, which was positive, and sepsis, which also was contributing to the relative hypovolemia and contributing to the hypertension. So this person ways how we can have a complicated situation sorted out by echocardiogram. Let's talk about chest pain. If the person presents with chest pain in the emergency room with or without breathlessness, so many diagnoses could be there. And echocardiography is definitely a condition, a test which could help us whether this chest pain is cardiac or not. If it is cardiac, what could be the etiology? And if it is cardiac, what kind of threatening situation can we have? A classical situation, this 29 years young gentleman presents to our emergency, and there were no cardiovascular risk factors, but he had 2 hours of chest pain. And mind it, there were certain subtle changes in the upcoding ST segment, but lead 3 was showing T-wave inversions. What we did was an echocardiogram, and lo and behold, we find the apex is still completely akinetic. So obviously, this gentleman was having a suspected coronary artery disease. And what we did was we did angiogram, found a tight left anterior descending austere, and this person was opened up, angioplasty was done, and this person remained with a normal systolic function for the whole year now. So this is where echocardiogram can add on. The important thing is echocardiogram does not make the diagnosis of acute ongoing MI, and that is why thrombolysis is not indicated on the basis of echocardiogram. However, it can promote you to take a early intervention or invasive strategy to save lives. And as luck would have it, 40 to 60% of people with chest pain and later having confirmed myocardial infarction have non-diagnostic ECGs, and that is something which we have to keep in mind. Dissection of aorta, again, in 2D and 3Ds can give. And one more thing, I was talking about the lung ultrasound. now today, if we have lung ultrasound, it can also give us another reason to believe. You can see the ragged edges here. This is what we call as shed sign or suggestive of in consolidation or pneumonia. And this could be also diagnosed in the emergency through ultrasound. I have a very interesting case here, just like what I gave you in the previous one. The 62 years young gentleman came with a diagnosis of anti-ABL MI previously and yet had chest pain. And this is something which is important, that once the person was already diagnosed an MI 2 weeks back, it did not mean that that person cannot have chest pain again. The second time chest pain could be infarct extension, but there could be other complications as well. And so this person was in the emergency with NYHA class 3 breathlessness and chest pain again. What was important is that, okay, apex was infarcted, but can you see this? This, you can follow my cursor here. There was a VSD at the apex. And if you look at the other view with the color, you can see the color flow through the VSD. But it's not only that. The other thing, because this guy was a smoker as well, you can see this swirling kind of a clot in the right atrium. So this person had a multitude of reasons for having breathlessness and chest pain. He had a VSD emanating after a week, 10 days of thrombolized anti-ABL infarct. Along with that, pulmonary embolism because of deep vein thrombosis, which had mobilized the clot. So these things have to be only possible once we keep our minds open. This patient was straight away taken to the CT scan, and there was pulmonary embolism which was seen. And along with that pulmonary embolism, that the venous veins were still having thrombus. You can see the leg veins having clots in the femoral side on the right side. So what could be done on this patient? This patient was taken directly to the operating room, in the hybrid operating room. Intra-aortic balloon pump was inserted, and CAG was done on the operating table itself. We can see the right coronary was okay, but the left anterior descending was completely occluded. So this patient had a bypass SVG to LED, RA clot removal, VSD flat closure, pulmonary thromboembolectomy, and an IVC filter. And this patient has completed 7 years of follow-up and is doing still very well. This case was an interesting one when echocardiogram could tell us not one, but multiple things. Last but not the least, if a person presents to the emergency room with breathlessness, so many things, severe MR, pulmonary embolism, tamponade, and other complications of myocardial infarction should be definitely thought about. In this particular patient, in POL MI, lateral posterior MI, but you can see the flail PML leading to severe pulmonary mitral regurgitation as a cause of mitral breathlessness and LVL. And there was another patient who had a prosthetic valve. I have echocardiogram in the emergency room can show us obstruction with the clot in the prosthetic valve as a possible reason for breathlessness. And these people can actually be taken to the operating room because this big clot should not be thrombolized. There is more risk of thromboembolism to the brain and strokes. These patients should be taken to the operating room as a second surgery, as a first priority. There could be other reasons for breathlessness which could not be cardiac. The cardiac reason could all be evaluated in this particular state. You can see the B lines. These are all the lines which can be seen as a part of heart failure. And for this, the cursor is placed in anterior chest in the upper quadrant to look at the curly V lines. And also the pleural effusions. Both the things can be seen as ultrasound chest. Pneumothorax is another thing we can look at. I will end my talk here with a small bit about stroke. If a person presents to us in stroke, the commonest reason for stroke presenting in the emergency room is most often than not a cardiovascular erosion. And that is why echocardiogram comes into fore. In this particular patient, this patient had an anti-MI earlier, but you can see this big clot, and in the 3D echo itself, this is lysening clot here, probably leading to the cause of stroke. The other thing was, in this particular patient, you can see the big left atrial clot, and sometimes you have to do transesophageal echocardiogram in the emergency room to look at the presence of clots as a reason. But never forget to look at the shunt, the PFOs through the atrial septum as a cause of stroke, which could be highlighted in the emergency room itself. This particular patient also can see, you can see the vegetation here in the catheter tip, who was on dialysis, and as was the cause of the stroke because it went through the PFO. So, ladies and gentlemen, I would end my talk here that echocardiogram is a third eye for us in the emergency room. It can give much more structural and functional and hemodynamic information. Let us know whether it is cardiac in origin or not. Specifically, if the person has had a myocardial infarction, let us know about the complications of myocardial infarction, and timely intervention can be then planned as a triaging measure. Thank you. Thank you for your attention.
Thank you, Dr. Sanjay Mittal, for that very informative lecture. We are basically physicians, and we commonly visit emergencies and ICUs. And as you rightly said, there is not the cardiologist in the emergency room. It's mainly the intensivist, or most often the senior residents and residents who do these point of care echos. As a physician, I have two areas of interest. One is, as you mentioned in one of your cases, the dengue fever patient. Now, we see a lot of these dengue fever patients. And here what we see is the problem of plasma leakage and when to give fluid and for how much. Now, do you think that IVC size is, or collapsibility or its size or respiratory variation is a good indicator for fluid administration, or it has some confounders?
That's a wonderful question. You know, you very eminently pointed out this person had dengue positive, but had also sepsis, and both sepsis as well as dengue can lead to vasculitis and vascular leakage phenomenon, which would mean that there would be third spacing. Even if you give a lot of volume in these patients, it would always go into the third space and never expand the volume into the venous system. So you are absolutely right. You have to be judicious in use. Inotropes, yes, noradrenaline, sometimes steroids and other treatment has to be given. But volume replacement is essential. I mean, I would definitely keep that under my wings when I see the IVC which is empty, because this means there is no filling pressure. Even if you keep on giving inotropes in this particular patient, if the volume is not there, the blood pressure is not going to come up. I would, in these type of scenarios, when I'm suspecting septicemia and or dengue syndrome, noradrenaline and vasopressin probably would get a precedence, despite the fact that the person has left ventricular systolic dysfunction. So fortunately, this person did do well with the antibiotic coverage and the judicious use of volume replacements along with inotropes, and slowly we could wean off the inotropes, and he's doing fine. But you are absolutely right. We have to take a call at that time.
Thank you, sir. Thank you.
Dr. Mittal, patient is on a ventilator, he develops cardiogenic shock. So does it interfere with the hemodynamic assessment of the cardiogenic shock so as to plan optimum therapy?
Absolutely. That's a wonderful question. Once the person is on ventilator, specifically positive pressure ventilation, the respiratory changes would not be amenable on the IVC. And however, whenever we are doing a positive pressure ventilation, the intrathoracic pressure is probably for all period of time through the respiratory cycle higher, which would mean the IVC would have that much higher size. So the size as well as the inspiratory and expiratory collapse or changes would not be amenable in the IVC. However, the volume status can definitely be assessed by just looking at the jugular veins sometimes, and the extreme of volumes can definitely be assessed. That means if the IVC is more than 2 centimeter in size, that is definitely hypervolemic. And if the IVC, despite the ventilator, is less than 1 centimeter in size, that is hypovolemic. So, I mean, the extreme of hypovolemias and hypervolemias can definitely be assessed. If you are in a situation of dilemma, then there could be other mechanisms which you can assess. You know, what I very clearly mentioned in the first case I showed you, there was hardly any volume in the left ventricle, left atrium, RA and RV. So if the volumes in the cardiac chambers is small, that also can handle, can be suggestive of hypovolemia. And last point I would like to make here, when the person is already on positive pressure ventilation, giving a fluid challenge of 200 ml saline over a period of half an hour would never hurt because the person is already ventilated. You can take care of the oxygenation at that time. So I usually, whenever I have a doubt or dilemma, I do a fluid challenge and just assess the hemodynamic response.
Sir, one last.
There is another, whenever, in a very obese patient, it's very difficult to get a subcostal view, especially is on a ventilator. So even assessing the JVP also can give an idea about the volume status.
Absolutely. I 100% agree. I think echocardiogram is being used for IVC assessment because as a completion of the tool. But I think some other way we are forgetting to look at the clinical science, the jugular venous. Let's leave jugular venous aside. If a person who has ejection fraction of 20%, there was a gentleman in my ICU who was just having ejection fraction of 20%, my follow-up case, and was on double inotropes. I come in the morning, the person was on 2 inotropes, pressure was still 85-90. What I find is the person is lying completely flat, no breathlessness, respiratory rate 12 to 14 cycles per minute, oxygen pretty well maintained. I said, there's something wrong. This guy is lying absolutely flat. Are we just over-diuresing him? Because just a tagline 20% ejection fraction sometimes makes you react and don't even think about the person actually having hypovolemia. This person actually, then I looked at the IVC, it was collapsing, and I gave him 200 ml saline, and we could take off the inotropes. What I'm saying is, you are absolutely right. Sometimes the clinical sense, good clinical examination and acumen can help you a lot.
Dr. Mittal, in your experience, many times in emergency room, patients come with severe chest pain and ECG is normal or some non-specific changes. In this type of situation, have you found that doing echocardiography predates or antedates the occurrence of ECG changes later on? And you can diagnose ischemia by doing an echo even before the ECG changes come.
Yes and no. Yes, in the sense that if I'm there, I'll definitely do it. But as I said, most of the times in the emergency room, I'm not there. Even a best of the cardiologists may not be there. It may be just as you said, somebody said here, Dr. Sharma said, maybe just the residents or maybe just the emergency doctors. So gross wall motion abnormalities can be picked up by them, but subtle wall motion abnormalities, probably they'll miss out. And that is why I think I do not want to base my diagnosis of ischemia or infarction on the basis of echocardiogram. But yes, it has a positive predictive value that if you have detected a wall motion abnormality, in absence of ECG changes, this is a stronger indication that you should be more tending towards an invasive measure and take that person to the cath lab. I have seen that in my clinical presence during the daytime when the person comes and with the chest pain. Well, that is my stethoscope. And there is an echo machine, ultrasound machine in the emergency room with us in our hospital. As soon as I come there, I wheel in there and just look at the echocardiogram and make the diagnosis of ischemia or not. But I would say again, my clinical sense would take the precedence. If I'm convinced the pain described by the patient is suggestive of cardiac origin, forget about the ECG. I think I have to take the decision to take the person to cath lab. You are absolutely right. We cannot be waiting for the TROP-I reports to come. Even if they are negative, it just means that by that time, the myocardial injury hasn't happened. But would it happen subsequently is not what we are going to be waiting for. Yes, for exclusion of myocardial infarction, you will have to have a negative report of troponin I, but a first report of negative troponin I does not exclude a myocardial infarction in this setting. So you are absolutely right. My clinical sense would be dependent on my evaluation of the chest pain and the clinical presentation of the patient, subtle signs on the ECG, and in certain situations, echocardiogram definitely helps me not only in detecting, but also predicting which arterial territory it would be.
Dr. Mittal, suppose the patient is already in an ICU, he develops chest pain, suspicious of myocardial infarction. Besides conventional echocardiography, does regional strain adds any value or it does not matter?
Dr. Manoria, it does help. But again, as I said, who is doing the echocardiogram and where? A fresh perfusion defect, which can be detected on a contrast echo, can be revealing much more.
And sometimes you have very mobile clot in the LV. What would be your strategy? Anticoagulants or removal? Very likely to detach the clot.
You know, if I was in Alice in Wonderland situation, I would remove it by surgical route. But I'm 100% sure no surgeon is going to touch an acute myocardial infarction patient and do a ventriculotomy. Because specifically, clots would form more commonly in anterior wall myocardial infarction. And apex is going to be likely involved in those patients. And the route of ventriculotomy is through the apex. The myocardium is going to be so friable, people are going to be dreading going into the operating room. Yes, if it has been less than 72 hours, the myocardium still is not so friable, can be attempted, or we should wait for at least 2 weeks. And that is the time frame then you have to immobilize, give adequate anticoagulation and assessment of the risk. Otherwise, could be explained to the patient.
So thank you, Dr. Mittal, for a very informative and illustrious talk. We move on to the last session, and this is by Dr. Amrish Agrawal, renowned cardiologist from UAE. He will be talking on amyloidosis, current concepts and future direction. I'll request Dr. Parashar to chair this session, and Dr. Murthy if she's there. Dr. Parashar.
Hello.
Yes.
Yes, Dr. Parashar. Yes. Thank you very much for the invitation, Dr. Manoria. And,
you are mute.
Yeah, I'm not muted now. Am I hear you?
Dr. Parashar is on mute. He wanted to speak. Dr. Parashar, you are on mute.
Hello. Are you getting?
Yes.
Hello.
Yes,
I
yes.
can hear the voice.
We are having Dr. Agrawal who will talk on this amyloidosis, which is very rare disease, but very important to learn about the effect of the amyloidosis in different parts of the body, like heart, liver, and kidney. So I will request Dr. Agrawal to continue his lecture, please.
Thank you, Dr. Parashar, and thank you, Dr. Manoria, to ask him to give a talk. Actually, amyloidosis is not a new thing. We have been reading about amyloidosis from the time of pathology textbook. I remember when I was an MBBS and the textbook amyloidosis were there. And the only thing I remember from that time was that Congo red staining, because it's a very unusual term to be used. But as a clinician, we are now recognizing the heart failure with preserved ejection fraction is an important component in cardiology. And now we know that it is the most predominant type of heart failure seen in clinical practice. But when it comes to etiology of preserved ejection fraction, there are a number of etiologies a clinician has to encounter. So it's a one phenotype with many causes. It can occur due to ischemia, can occur to congenital heart disease, and it can occur in aortic stenosis, hypertension, and so on. But for today's talk, we are going to focus on two components of preserved ejection fraction, which occur due to restrictive cardiomyopathy or more commonly due to infiltrative cardiomyopathy. Now, among the infiltrative cardiomyopathy, there are many causes of infiltrative cardiomyopathy, and but we are going to focus today a little bit on cardiac amyloidosis, which has been there for a long time, like I said, but it is a common unrecognized cause of infiltrative cardiomyopathy, which can give rise to heart failure with preserved ejection fraction. From the time we discovered the new therapeutic and the treatment and the diagnostic modalities, there is tremendous research, tremendous upbeat in the number of research papers. And as you can see, the number of research papers which are shown is continuously increasing. Not only that, it is because of extracellular deposition of misfolded protein that is called amyloid. And how this misfolded protein occurs is we can understand from this diagram. It is nothing. This misfolded protein is nothing but the children of ATTR of TTR protein, and TTR protein we know is a carrier protein for thyroxine inside the blood. This protein is inside the liver, and when it comes to the liver, it comes as a tetramer. So there are 4 submolecules which are attached as a single molecule. These 4 subunits, due to some reasons, and we will see this reason later on, this dissociates into the components. So first it dissociates into dimer, and this is a rate limiting step. And the D-dimer and the dimers dissociate into monomers, and these monomers then they straighten out and find the fibrils, and these fibrils then become deposited in the extracellular tissue inside the heart and the peripheral tissues, giving rise to the typical pattern of the preserved ejection fraction and the polyneuropathy, which is the common manifestations of cardiac amyloidosis. Now today we are not going to discuss the systemic amyloidosis. We are going to focus on ATTR amyloidosis, which is the correctable cause because we have now therapeutic modalities to look after in this treatment pattern. Now, this commonly can occur due to multiple causes, but two divisions which are commonly used is the hereditary pattern. The hereditary pattern is a single point mutation which causes this phenomena which we described before to occur, and it's got a geographic clustering. Is common in America, and it's apparently that the Villen mutation, which is located in the 122 chromosome, is noted in is up to 2 to 3.5% of Black Americans. So that is why so much emphasis is trying to look at the cause. And there is a geographical clustering which occurs in the European area. In whatever in UAE we have seen the cases, they are all turned out to be wild type cases. So it is a wild type amyloidosis, is thought to be idiopathic, non-hereditary, predominantly occurring in the senile age, and has got innate ability to aggregate into insoluble amyloid fibrils. And there is a cardiac involvement, and there's a neuropathy. Typically, neuropathy is seen in 25% cases of ATTR cardiomyopathy. So we don't know what is the incidence and what is the prevalence of disease, but what we are understanding that common condition which we see in cardiology, amyloidosis contribute a significant contribution. For example, if you take the population of preserved ejection fraction, up to 13% of population can have cardiac amyloidosis, 16% can have ATTR cardiomyopathy in a patient with severe aortic stenosis. I mean, how many of us are actually looking for severe aortic stenosis and looking for this amyloidosis? We see the severe AS all the time, and this is particularly true when we look at the subset of low gradient, low flow aortic stenosis. Not only that, hypertrophic cardiomyopathy is connected with a symmetrical hypertrophy of the heart, and the data shows that in hypertrophic cardiomyopathy, up to 10% of population can have ATTR cardiomyopathy, and 10% of cardiac tunnel syndrome, particularly bilateral carpal tunnel syndrome, are having ATTR cardiomyopathy. In our hospital, anybody who has got a bilateral carpal tunnel syndrome, orthopedic refer to us routinely, and we'll do a workup for cardiac amyloidosis. So there are certain red flags. We are clinicians. We all are clinicians. We see the patients. The patient don't come with the diagnosis written on the forehead. So we have to have certain red flags, certain area of suspicion where we have to look for cardiac amyloidosis much more carefully. It is particularly when there is a heart failure with preservation infection, in which the thickening of the heart has got a lamination, or we can say has got a sparkling pattern. So as a wall thickening due to amyloid fibril deposition, mild increase in troponin levels of multiple occasions. So these are the patients in which the troponins have come multiple times elevated, elevated, and some of these patients will undergo angiography because troponin elevations, and we will tell them that you have a normal troponin. Then one thing is that NT-proBNP is always elevated out of proportion to the patient's clinical cardiac condition. So the NT-proBNP in the range of 5,000, 10,000, and the patient is asymptomatic, and there's certain ECG pattern which we see later on. And then there are neurological polyneuropathy, which can be seen, but we don't see in our clinical practice because we are cardiologists, and particularly history of bilateral carpal tunnel syndrome, which will see my neurologist and orthopedician directly. So what are the ECG pattern we talk about? So the ECG pattern, this is a typical ECG of a patient with atrial cardiomyopathy, and you can see there's a pseudo-infarct pattern without left ventricular branch block in 70% of cases. In addition, there's a discordant between the left ventricular wall thickening and the QRS voltages. So if you see the echocardiogram, I'm going to show you a thick left ventricle, but in the echo and the ECG, the evidence of left ventricular hypertrophy is not very, very commonly seen. And sometimes of the protein, fibrillar protein in the conducting tissue, there is a AV nodal blockade. Apart from AV nodal blockade, one common cardiac condition which is seen in the ECG pattern is the presence of atrial fibrillation. So atrial fibrillation can be seen in nearly 50% of cases. If you have somebody with heart failure, preserved EF, absence of voltage on the ECG, and atrial fibrillation, the index of suspicion in such a scenario should be quite strong. The thing is that once you have this diagnosis, it's very important to make a diagnosis rapidly because these patients have a predominantly poor median survival. Typically, once the patient diagnosed, most of the patient will die within 5 years, and standard therapy for the heart failure is ineffective because the blood pressure always on the lower side. So despite having hypertrophy, their blood pressure on the lower side, and typically the medicine which we use for the heart failure, beta blockers, ACE inhibitors, they cause hypertension and fatigue, and they actually are not at all beneficially. So that is why most of the patients are misdiagnosis, and typically what has been shown in the literature that many of the patients, they visit up to 5 physicians till the time diagnosis of the amyloidosis is made. It's a progressive disease and with high mortality, and early treatment, as I show you, is advantageous. So hence it is very, very useful. So let me start with a case. And this case is a patient with hypertension, with control and hypertrophy and heart failure with preservation infection. Obviously, she had kidney failure, which led to dialysis and was admitted with a cardiac failure for him. Hemoglobin was 10.5, EC normal voltage, no LVH despite hypertension, and despite elevation the echocardiogram, and the rhythm is sinus, and she was not having atrial fibrillation for her. Then we did a workup for her. We found a proBNP multiple times in the hospital visits. Her proBNP is elevated, and you can see the elevation of proBNP is the range of 1,000. Not only that, the number of troponins in the emergency department have been elevated in the range of 900 to 1400. So there's a persistently elevated troponin. Now, when we took this patient clinical scenario and we discussed with the red flags of amyloidosis, actually our patient can satisfy many of the red flags. For example, there is a heart failure with preservation infection, there is elevated troponin, there's a proBNP, and there is a blood pressure on the normal side. So we have to actually think of amyloidosis. So first test, if Dr. Bansal will agree with me, we'll obviously do echocardiogram for him. And this is the pattern of echocardiogram we saw in our practice, that you can see that the left ventricle is thickened and hypertrophied. There is a increased granularity of the left ventricle myocardium. There is a small trivial pericardial effusion, which is very, very seen. So we can actually see that the thickening of the left ventricle and a small pericardial effusion is very, very important to do a strain imaging for a patient. One of the characteristic thing in the echocardiogram is the strain imaging in the patient amyloidosis. And our patient, we underwent strain imaging, and you can actually see in the strain imaging the bases of the left ventricle, all the three views, the apical 3-chamber view, 2-chamber view, and the 4-chamber view. You can actually see the base of the left ventricle are less darker red in color. They are less brighter red in color, and the apex of the left ventricle are more brighter in color. So the discordance that the apex of the left ventricle is having more stronger contractility than the base of the left ventricle. And this can be actually seen when we plot the images by using the strain imaging. And you can see that the bases of the left ventricle have reduced contractility, and the apex of the left ventricle, which is the center of the image, is having more brisker contractility. So actually there's a gradient from the base of the left ventricle to the apex of the left ventricle. And this gradient, what we describe in the books, is called the cherry on the top of the ice cream, is one of the patterns which have been described in the cardiac amyloidosis. So our patient, we went and did an angiogram for her because there are multiple cardio risk factors and the troponin is elevated. And you can see that the troponin, the angiogram is normal, the coronary arteries are normal with a smooth lumen for him. So echocardiogram has been described as one of the features to be looked in the patient with cardiac amyloidosis, but the data is showing and the clinical expert is showing it is the first line evaluation because there are multiple patterns which will identify the echocardiogram, but none of the findings are actually obligate. So none of the findings are actually obligate. But so till this time, how do you diagnose this patient? Till the time of advent of nuclear cardiology, the pattern was not very clear. Echo can be suggestive. Cardiac MRI can point towards the inflammatory process, and there are certain patterns of cardiac MRI which can be suggestive. And for the long time, endomyocardial biopsy, because we are cardiologists, is much more specific, and the congruent staining were the only diagnostic tool available. Fat biopsies are good for the systemic amyloidosis, but for cardiac amyloidosis or ATTR amyloidosis, they are not very strongly positive for him. But however, the scientists discovered the use of technician labeled bone avid compounds allow us to make the non-invasive diagnosis of cardiac amyloidosis much more sensitively and specifically. And the reason for binding of this amyloid deposits, the reason for binding of these bone avid compounds to the amyloid deposits actually remain unknown. We don't know why the amyloid have a special predilection for the 99 technician bone avid scanning. There are a number of bone avid compounds which can be used, but in our hospital we use pyrophosphate compound. So the pyrophosphate is common used, but in America and other Europe, they have different compounds. They all do the same job by binding to the cardiac proteins, amyloid protein inside the heart much more, and this can lighten up on the nuclear scan for him. So how do we look into it? We look into it by two ways. We can do a semi-quantitative way and a qualitative way. In the semi-qualitative way, on the left side, we can see the planar images and the spec images of the nuclear scan. It may appear very complex, but actually it's like an X-ray imaging. So you can see that on the left side, what you can see that the heart and the ribs are actually more bright in the heart, and this is a grade 0. That means this is not pattern. There is no uptake of heart as compared to the ribs. And on the right hand side, you can see on this one, on this side, totally on the right hand side, you can see actually the heart is lightened up. So the heart is like an electrical bulb as compared to the ribs. That means the heart has taken the scan much more powerfully than the ribs. And this is a grade 3. Grade 3 is defined by uptake greater than the rib uptake with a mild or absent uptake. And this is a pattern which is quite suggestive of cardiac amyloidosis. We can even do a quantitative scanning by putting a tracer marking on the rib or the quintilateral rib and compare with the uptake on the heart. So here you can see we have put a marker on the rib and we have put a marker on the heart, and we can look at the uptake count in the circle 1 compared to circle 2, and the biopsy proven ATTR typically have the ratio of 2:1. So these are the things which you can see, and the pyrophosphate compound is kind of diagnostic. So you can see the unaffected control, and those patients with ATTR cardiomyopathy, the data shows that the sensitivity of positive scan for detecting transthyretin amyloid deposits is 99%, but the specificity in the range of 85%. Why? Because the amyloid deposits uptake is just not located to ATTR cardiomyopathy. Systemic amyloidosis can also uptake. That is why sensitivity is very high, but the specificity is low. And how to distinguish between the two, we will go a little bit down the line. So it appears that if you do a scanning, and this nuclear scanning is available in our hospital and is available in hundreds of centers in India, you can actually come to a great conclusion to make out if this person has got a strong suspicion of cardiac amyloidosis or not. So what are the conditions in which the bones can become positive with the ATTR cardiomyopathy? That happens in the case in which the air light chains are elevated. So that means what? If you do a monoclonal protein antibodies and the monoclonal protein assays in the blood, and these assays are negative, then a positive scan with a negative monoclonal protein or a negative light chains is kind of very high specific, and the specificity appears nearly 100%. That means everybody in which you suspect, you have to order 2 tests. One is a pyrophosphate scanning of the heart, and you have to order a kappa chain, lambda chain. So these are the tests you have to order. You have to order kappa chain, lambda chain, the ratio, and you have to order serum and urine immunofixation electrophoresis. These tests are not done in our hospital. We send the sample to Germany, and typically the sample takes 3 weeks to come, but the nuclear scan is done in our hospital. If these 2 tests are positive, a positive nuclear scan, a negative immunofixation scan, a negative light chain, and the kappa chain, that means this is nearly 100% specific for kind of amyloidosis. So what are the lessons we can derive from the amyloidosis trial? In order to understand the treatment, one thing we can understand, more is the deposition of amyloid fiber versus the outcome. Less is the amyloid fibers, better is the prognosis. Unfortunately, when the patient comes to us, there is a lot of deposition of amyloid in the patient heart because they become, that is how they become symptomatic. Nobody comes to us when they are symptomatic, the amyloid fibers just starting deposits in the heart. So we have to have a process in which less amount of amyloid fibers are produced and some amount of amyloid is removed from the heart. So the clearance of amyloid occurs naturally and occurs in different rate in different organ. We have to reduce the production of amyloid and we have to increase the clearance as shown in the on the right hand side in the circular diagram for him. And by reducing amyloid production, the rate of clearance exceeds the rate of formation, then amyloid regression will occur. Among the steps of amyloid formation to the amyloid fiber deposition, because like we discussed, the amyloid fibers are made in the liver as a tetramer, and these tetramers are dissociated into monomers and misfolded state deposition. We can interfere at this multiple ways, and the most common way is to prevent the dissociation of a tetramer into dimer and monomer. What we call is the stabilization. Why this is an important step? Because the rate limiting step of this pathophysiology. This particular step determines the process of dissociation, and this rate limiting step. And there are a number of processes, a number of molecules which can act. We can act as an NACD molecule, which is diffusion, but that is now more used in practice now. But we have selective TTR stabilizers, and we have a tafidamidis, and we have an AG10, which is called acoramidis in the clinical practice. Trials are undergoing, but among them, tafidamidis is approved for clinical practice and is available in India as well as available in UAE. We can obviously act on the liver by doing heterotropic liver transplantation, and or we can do some gene silencing technique, which we'll discuss in the later on. And these gene silencing techniques are in the common mechanism. We know similar mechanism, inclisiran, the siRNA and ASO silencing mechanisms, and they're applicable to both for wild types and hereditary amyloidosis. We can actually try to remove the amyloid fibril from deposit states. So there are therapies which are working on it. What's the combination of doxycycline with TU's DCA, and there are monoclonal antibodies which are in the process and undergoing clinical trials, phase 3 trials in the population for him. Among them, what is available now, the therapy which is available now, there are many therapies available, but the therapy which is very, very specific of cardiac amyloidosis is tafamidis, and it is a selective stabilizer for the TTR cardiomyopathy. It stabilizes the TTR tetramer into stabilized form. It is a derivative of NASAD, and it binds to the thyroxine binding sites for both variant and wild type TTR protein with a very high affinity and selectively. It inhibits the dissociation into monomer, and thereby decreasing the formation of amyloid fibril. And obviously, if less fibrils are there, less fibrils are deposited. The data shows it's oral molecule. The good advantage is oral molecule to be taken daily, and the data shows if you give 60 milligram oral dose, you actually inhibit the dissociation of ATTR fibers protein by 100%. So by giving 60 milligram dose every day, you can actually dissociate into subunits by nearly 100%. And it was actually tested in a clinical trial which came in 2018 called as the ATTR ACT trial. Now, ATTR ACT trial we have discussed with Dr. Manoria's meeting multiple times, is a trial which looked in patients impact of tafamidis in the patients with ATTR cardiomyopathy. And after screening, they were randomized into 2 doses of tafamidis, so 80 milligram and 20 milligram. This is a different molecule. The dose of 80 milligram is equivalent to dose of 61 milligram, which is available in the market. So it tested 2 doses against the placebo and tested for 30 months in the ratio of 2:1:2, 80 milligram, 20 milligram of placebo, and they were stratified by the wild type and variant type of amyloidosis and the disease severity. What did the result showed? The result showed that the pooled data of tafamidis showed a 30% reduction in the risk of all-cause mortality. So very hard endpoint, cardiac mortality came down by 30%. And the impact did not occur initially. Impact occurred after some time down the line, and obviously that is because you have to remove the molecule from the deposited tissues in order to impact in the clinical condition to occur. So not only that, they also showed that the first cardiovascular heart failure hospitalization was reduced by 32%, and that difference was seen by the end of 6 months. So reduction in cardiovascular mortality and reduction in the heart failure hospitalization, the improvement of secondary endpoints, and the secondary endpoints were 6 minutes walk test, which improved by 76 meters. Improvement are quite rapidly, and the improvement in the consensus questionnaire for cardiomyopathy, 14 basis point. So patient felt better, patient lived longer, and less number of patients were readmitted to the hospital with the cardiac failure for in the population. So the ATR cardiomyopathy was the first trial to show impact in the heart failure with preservation fraction. Now we have SGLT inhibitor. The SGLT inhibitor came in 2021, but in 2018, the first time a drug was shown to reduce the mortality and morbidity in the population with heart failure with preservation fraction due to cardiac amyloidosis. And this is the first time a heart failure drug is effective on the hard endpoints by acting on the myocardium, rather than acting on the peripheral neurohormonal mechanism. This trial, after 30 months, went into a 5 years extension in which all the people, even the placebo arm, they received tafamidis, and the results showed, the extension arm showed that even if you give the trial drug after 3 months, the delay has got impact. Those populations which received tafamidis early in the course, they had a much more better survival. The difference between the two arms were in the range of 41%. That means what? More early you give, the less the amount of protein deposits, fibrous deposits inside the heart, and more is the protein removed from the heart, and better is the patient outcome. So coming further, we have another therapeutic targets for him. We know that the protein is synthesized in the liver, in the liver inside the nucleus, and it is secreted in the body. So the ATTR protein is synthesized in the nucleus and is secreted in the plasma, very dissociated into monomers. And this is acted upon by stabilizers such as tafamidis. However, we can act upstream. We can act upstream inside the liver by many other mechanisms. Obviously, we talked about liver transplantation. This was tried in 1950s, but obviously nobody is going to do a liver transplantation for ATTR cardiomyopathy unless the person is a fulminant hepatic failure. Now we have two other technologies, the gene silencing technologies. They silence the gene by messenger RNA, which produce the ATTR protein. So we are actually attacking the molecule at the site of synthesis, and so the less amount of ATTR protein is formed by using silencing technologies. One is the RNA therapies, small insulin RNA such as patisiran, similar to mechanism of inclisiran, and one is the ASO mechanism, which is an inotersen and epintersen. Among them, epintersen is commercially available in UAE, made by AstraZeneca, and is already approved for hereditary cardiomyopathy for him. So how this mechanism act? If you take the first mechanism, which is called the cRNA mechanism, what the mechanism does, and the two molecules which are prototype, the patisiran to be given every 3 weeks and votusiran to be given a monthly injection, they bind to the RISC complex. So they act with the similar mechanisms such as the inclisiran. These are given by the NEC complexes. These complexes are internalized by the liver, and then they bind to the RISC complex of dissociating, and they keep on actively searching for the messenger RNA which encode for ATTR protein. Once they find the messenger RNA, they slice it, thereby silencing the production. So they actually call degeneration of the messenger RNA and thereby silencing the production. And the very powerful mechanisms have been tested in peripheral neuropathy, found to be very, very effective, but also the trials are undergoing for cardiac amyloidosis. Then there's another mechanism which is called the antisense oligonucleotide mechanisms. What it does, that antisense oligonucleotides are small sequences. They are long sequences of 60 to 20 nucleotide long, which bind to the messenger RNA. And once it binds to the messenger RNA, it directs to the enzyme RNA H1 and cleaves it, thereby halting the production. So both the mechanism by different ways actually it destroys the messenger RNA, which encodes for the ATTR protein, and thereby silencing the production. And these trials are underway, and epintersen is available in UAE, licensed for peripheral neuropathy. But the speakers, they have also tried for cardiac amyloidosis and found to be very, very effective. Has to be given monthly, once injection on a subcutaneous basis. So question comes to us, once we diagnose the patient amyloidosis, and we start the treatment, obviously we can say that patient live longer and the patient of heart failure hospitalization. But like lipid therapy, like heart failure, blood pressure medicines, how do we monitor patients? The patients and the provider, they commonly wonder if medicines such as tafamidis is working, and they naturally seek measure efficiency. This is not wrong on their part. This is very intuitive. The assays for TTF stabilizations are not currently clinically available. And if they are available, they are performed in the laboratory under non-physiological conditions. We can do imaging by looking at the MRI patterns, but this is a long delay. But in order for the changes to occur in MRI, we have to wait for 1 year, and nobody can wait for 1 year to decide if the drug is working or not. So the people started working on it. And one way you can look at is to look at the TTR levels. Obviously, TTR level is the blood. Occurs before the dissociation, and more dissociation occurs, less is the amount of TTR level. Less dissociation occurs, more is the amount of TTR level. So lower serum TTR level predicts increased mortality in the patients with the atrial cardiomyopathy. And this proof of concept was tested and was published in GACC in 2021. And they found that in the populations of atrial cardiomyopathy who received therapies and they were monitored at 3 months to 12 months down the line, there was absolute improvement in the ATTR level, indicating more stabilization, more availability of ATTR protein, and less downstream. As you can see, the TTR proteins are going up, and the percentage change in the TTR level was also seen in this population. Coming further, where were we heading? Like all science, we are heading towards the genetic therapy for him. And we will come back to this slide a little bit later. But the future is genetic therapy for atrial cardiomyopathy. And the future, what do you mean by future of genetic therapy for atrial cardiomyopathy? We can actually use the newer genetic modalities to give the treatment one time, a single one-time treatment to destroy the gene which is encoding for ATTR protein. So this is upstream. We are talking directly at the level of genetic interference to destroy the gene so as to reduce the production of ATTR, so thereby halting the production of fibrinogen protein for him. And this can be done by the CRISPR technology. This technology is not at all much difficult to understand. So what this technology does, you take a lipid nanoparticles to the molecule, so the particle can be delivered to the liver. You infuse this by the blood, and the molecule will go inside and deliver the liver. Inside this liposome, lipid nanoparticle, what do you have? You have a Cas9 messenger RNA. Cas9 messenger RNA is a discovery of the century, we can say, and the people that receive a kind of prizes also for it. It is derived from Streptococcus pyogenes. What it does, once you have this one and you couple it with the specific RNA, once it attaches, it cuts the DNA into two portions. So the DNA is cut into two portions directly. Which portion of DNA is cut is the DNA which is identified by the single chain RNA. So there's a single chain RNA which identifies the portion of DNA to be cut. And this single chain RNA can be derived from multiple proteins. In our case, we are talking about TTR specific sgRNA, and this TTR specific sgRNA is coupled to this Cas9 messenger RNA, delivered inside the liver, identifies the DNA which encodes for that with the ATTR protein, cuts into both the ends, and thereby allow genetic engineering to be done for him, and long-term suppression of ATR protein. So this particular molecule, which is called the NTLA 2001 treatment, is the first in vivo CRISPR-Cas9 based therapeutic molecule. And like we said, it has got this pyogen based Cas9 protein and a specific TTR we call is TTR protein, which is called as messenger RNA, which specifically encodes for the TTR. And when you combine the two, they will select and they will do this one. So it causes a rapid and durable reduction in the circulating TTR protein levels. So unlike the amyloidosis where the increased levels are helpful, but here in this case, if you want to monitor, you have to monitor by the reduction of serum TTR protein level. The clinical efficacy and safeties have been evaluated in the clinical trials. Unlike thalassemia and the sickle cell, you will find a single time one-shot therapy, identify the patient, give them one injection, is going to be costing lakhs of rupees, probably in 1 crore, 2 crore rupees once it comes to the production, and this will knock off the protein. So I come to the end of the talk by giving one more talk, which I want to give is that how do you monitor the patient long-term by cardiac MRI? One way you can look is by changes in the extracellular volume. For example, if you take the patients which didn't receive the treatment is in the box patients here, and the left two and the center one, the left one of the patient who tougher with this, you can see without treatment, there's a gradual increase in the late gadolinium enhancement and the extracellular volume in the T1 weighted cardiac MRI for him. However, if you give the patient tougher noise, you can find actually there is stabilization. There is no increase in the late gadolinium enhancement and the extracellular volume, indicating that the process is arrested. And obviously, when the process is arrested, the body is going to clear the fibers naturally. And with this, I come to the end of the talk by saying that the earlier studies in both AA amyloidosis and the AL amyloidosis established the treatment paradigm between the deep reduction of amyloid precursors and the prognosis. That means what? You have to actually reduce the amyloid precursors to such an extent the body's own clearing process remove the amyloidosis from the body. Tafamidis, which is stabilizer, is approved for the treatment of atrial cardiomyopathy, and treatment is associated with reduction in all-cause mortality, cardiovascular hospitalization, improvement in the quality analysis such as the 6-minute walk test and the quality of life as compared to placebo. The gene silencers such as the cRNA and the ASO program work on the concept that circulating TTR is mainly liver derived and the knockdown of ATTR is likely to be well tolerated. Accelerated amyloid removal to complement the slowing process removes the holy grail, and monoclonal antibodies are in development for this particular segment for them. And obviously, the end result, the best will be a single gene therapy and the CRISPR, and I'm sure it is not far away. In 4 to 5 years down the line, we will have therapies which will be approved by FDA in the line. Thank you very much for your kind hearing. If there are any questions, I'll be happy to answer.
Thank you very much, Dr. Amri. You have focused on the cardiac amyloidosis. If you find that in general practice, the patients are coming with the chest pain, breathlessness, and somewhat and the enteropathies, the clinically eye symptoms. So, to whom you will consider for the diagnosis of the amyloidosis, especially the patient of a renal failure or having enteropathies or cardiomyopathy? What are the target people to whom you will investigate the amyloidosis, please?
This is a very good question. So the systemic amyloidosis affects the kidney. Systemic amyloidosis affects the kidney and one of the causes of renal failure. There is a treatment for it, and these treatments are not the one which are, they are cytotoxic treatment for it. We are talking about cardiac amyloidosis, particularly we are talking about amyloidosis, which is ATTR amyloidosis. And this particular ATTR amyloidosis, why we are looking specifically, because the diagnosis is very easy by doing a nuclear scan, and the treatment is available commercially. How do we diagnose it? By looking for the red flags. And which are the red flags we look for it? We look for the red flags in which the person is having preserved ejection fraction, which is a very common thing, and a thick heart. A thick heart with low voltages. A thick heart with the low voltages, when you couple it along with the elevated troponin, elevated proBNP, makes the diagnostic suspicion much more higher. Atrial fibrillation is one of the common things. If you are somebody with atrial fibrillation, heart failure with preserved ejection fraction, low voltages, then the diagnostic yield will increase. Bilateral carpal tunnel syndrome, very important area, which is not cardiology, but the polyneuropathy is the one thickened nerves, where the nerves become thickened with the amyloid deposits, and they give rise to bilateral carpal tunnel syndrome is another subset where the yield becomes much more higher. So you cannot do unselected tests for all the patients, you will be negative. You will keep a look for amyloidosis for some time, and one day you will find 3-4 cases coming consecutive to each other. So you have to look for this particular subset of patients.
Dr. Amrish, the acoramidis has also been approved by FDA, and the attribute CM trial was presented at AHA. So what is the difference between tafamidis and acoramidis?
Now, tafamidis and acoramidis, they are both different companies. I have not much idea about it. In our hospital, we are using tafamidis because that is available with us.
They say it is
Amrish, just one question. Sorry.
Yes.
One point which was mentioned by Dr. Naveen Nanda. He said a very simple bedside test, with which you can suspect that there is amyloidosis. Beside the wonderful presentation by Amrish, the cherry on top and low voltages but hypertrophy. If you go back, remember, we used to have the fundamental 2D imaging, and then came the harmonic imaging. So he's saying when you remove the harmonic imaging from the echo and come back to the fundamental imaging, if you still feel that the picture looks like harmonic imaging, suspect amyloidosis or any infiltration. So this, he said, is a very simple, cheap bedside test. With most of us, now we always condition our echo machines directly with harmonic imaging. But Dr. Manoria, I remember there was a time where we used to start with that. So just go back, remove it, and then still if you see, he is mentioned in 2 different occasions. Dr. Naveen Nanda, the father of echocardiography.
Yes. So you are right in the sense. You're right in the sense. Increased speckle appearance can occur in many cardiac conditions. Most common is hepatocardiomyopathy, can occur in patients with sarcoidosis, can occur in patients with Gaucher's disease, can also increase patient cardiac amyloidosis. So the increased inflated cardiomyopathy, you can use this pattern. But whether this pattern is specific for atrial cardiomyopathy, the only thing which is specific for atrial cardiomyopathy, which is not present other than inflated cardiomyopathy, is probably a GLS with the increased apical contractility and the reduced basal contractility. But from the apical pattern wise, it will be probably similar.
Yeah.
One more thing is that we commonly believe that the amyloidosis will give rise to an symmetrical hypertrophy of the heart, and hypertrophic cardiomyopathy will give rise to asymmetrical hypertrophy of the heart. But this is not true. Many of the patients with the hypertrophic cardiomyopathy will have symmetrical pattern, and nearly 20% of patients with the atrial cardiomyopathy will have an asymmetrical pattern. So this pattern, yes, it is suggestive, but not conclusive.
For that matter, cherry on top can also occur in some of these highly suggestive MRI. It's not 100%.
You are right, Dr. Manoria. I gave a talk a long time back in the European Society of Echo, that was in Vienna, and the topic of the talk was the left ventricular strain pattern in the patient with the pressure overload, and I showed many examples in which actually what happens when the heart becomes overloaded with the pressure, whether you talk about aortic stenosis or you talk about hypertrophic heart disease. The base of the left ventricle, because the radius of the heart is bigger at the base and shorter at the apex, the bases of the heart are affected more by the pressure than the apex of the heart, and they have a more longitudinal deformation abnormality than the apex of the heart. So this cherry of the top. So you have to take the ratio. If the base of the heart versus cherry of the heart of the top, the ratio is more than 4:1. The 4:1 pattern goes more in favor of atrial cardiomyopathy, and lower pattern goes in the favor of hypertrophic heart disease or aortic stenosis.
One more thing, you know, that
Hello.
sorry, so the fit about 10, now the tower is becoming so commonly done. 15% of patients of tower have got an amyloidosis. So even if you have done the right procedure, very costly, and the patient doesn't do well. So is it necessary to screen every patient of tower, especially elderly, to rule out amyloidosis?
This is an excellent point. Particularly, the cost of tower is hundreds of times as compared to the cost of single nuclear scan. Sometimes doing the immunofixation, they say that you have to do immunofixation before you ask the patient for a nuclear scan. But in our hospital, doing a nuclear scan is far more easier than to do the test, because the test is sent to Germany. So in our hospital, we will do the test, and that if the patient got a nuclear scan which is negative, this kind of excludes cardiac amyloidosis.
Rajiv.
Yeah, I just want to thank you, Dr. Amrish, for passing on tricks to general cardiologists like me. I'm not a specialist.
No. You're an expert.
I just want to know how do you change the harmonic and fundamental imaging, which Dr. Vinod Vijan talked about. I mean, should we learn from specific company engineers? Is it possible in every equipment or not? I mean, just my question.
There's a harmonic button you have to undo.
Button.
See, most of the machines are default. Unlike the old times where the machine will start with the normal single frequency and the harmonic, you have to press it. Most of the current machines are programmed in a way that the harmonic is default. I think so. Harmonic is default. If you find a pattern on the harmonic imaging, a bright pattern, see, harmonic imaging came in view because the imaging quality improves. So thickness of the heart will not change your harmonic versus normal imaging. What will change the heart is the echo texture of the images. So the echo texture is bright. It just tells you nothing but that you can think of infiltrated cardiomyopathy. It doesn't tell you what infiltration we're talking about.
Yeah.
So that's what it is there.
So, thank you very much. Thank you very much.
Thank you, Dr. Amrish. Thank you.
Thank you very much. Thank you very much for having me.
And I think all of us enjoyed the flashes of expertise of all our great speakers. Thank you very much, and we hope to meet soon in near future.
Thank you, Dr. Manoria, organizing a very good webinar.
Thank you, Dr. Manoria.
Thank you very much.
Yeah. Thank you all.
Thank you.
Thank you.
All. Yeah.
Bye, everybody.
Thank you.
Bye, Amrish.
Bye, Amrish.
Bye.
Dr. Amrish was very kind. Both of us were at APIACon yesterday, and today he has come for webinar.
So he's in India. US
he was in India, and now he's in Dubai.
Dubai, वापस हो गए. Okay. He's a great guy. Like P C Manoria himself.
I'm with you.